Ma'am, please start. You can unmute yourself. Thank you.
Okay, thank you. Good afternoon, everyone. A warm welcome to all of you in today's webinar. Recently, we have celebrated uh, Sickle Cell Anemia Day, World Sickle Cell Anemia Day on 19th June. So today we are going to have a lecture on sickle cell anemia by Dr. Amit Jain, who is going to tell us about sickle cell anemia for the awareness of sickle cell disease, its management, and diagnosis, management, and how to give support to the family. Uh, so this day is mainly celebrated for the awareness of sickle cell anemia. So today's first speaker is Dr. Amit Jain, who is pediatric hemato-oncologist, and he has special interest in benign and malignant hematology. Sir has done fellowship in pediatric hemato-oncology from MCGM Thalassemia Care, Pediatric Hemato-Oncology and Bone Marrow Transplant Center from Mumbai. And Sir has worked in pediatric hemato-onco and bone marrow transplant for more than 7 years. So he's having great experience in bone marrow transplant related complications. Sir has written guidelines and chapters in hemato-oncology. Sir is having many publications in different journals. And I request Dr. Amit Jain sir to tell us about the sickle cell anemia in children. Over to you, sir.
Thank you, ma'am, for the introduction. So without wasting time, I'll start my presentation. I'll try to cover everything possible. So just, is my slides visible?
Yes, sir.
Yes,
Yes, sir.
yes, we are visible.
Yeah. So we'll start. So this is the overview of my talk. I'll cover a brief background, followed by pathophysiology, presentation, diagnosis, management, and prevention of sickle cell anemia. So we'll start with a case of 8-year-old boy who was born of non-consanguineous marriage, tribal by community, was admitted with LRTI. So there was a history of dactylitis at near infantile age group, then followed by recurrent episodes of pain in the past. There was a history of transfusion twice in the past, and on examination, child has pallor and icterus with spleen of 2 centimeter, and currently he has been admitted with LRTI with a patch on the right side of the. So, sickle cell anemia is actually an inherited autosomal recessive condition in which hemoglobinopathy resulting from the point mutation in the hemoglobin gene on chromosome 11. Because of this substitution of valine for glutamic acid, the beta globin chain results in formation of HbS, which under low oxygen condition polymerizes and causing sickling of the cells. These sickle cells can cause microvascular occlusion, chronic hemolysis, and ischemia perfusion injury, leading to the complications. Now, as we are aware that sickle cell anemia is predominant in African countries, sub-Saharan African countries, America, and South Asia, especially in India. Going to India, so there is a belt, sickle belt, which from the west originates from Rajasthan and Gujarat, then central India, Madhya Pradesh, then Jharkhand, Odisha, and in south it tends to go to Andhra Pradesh, Telangana, and some part of the Kerala. So this is what we called as sickle belt, and in which the prevalence of sickle is very high. Moving to pathophysiology, because of this polymerization of RBCs leading to sickle cells, they have decreased deformability or increased fragility. which causes hemolysis because of the increased fragility, causing microvascular obstruction whenever they travel through the veins or arteries. When they stuck in the circulation, that causes tissue hypoxia and leading to acute or chronic manifestations, which will be discussed later. It also causes endovascular injuries because of the endothelial adhesions, which leads to chronic manifestations. So it can affect any part of the body acutely or chronically. So whenever the sickle cell stuck in the vasculature, it can cause problems. Beginning from the head, when it stuck in coronary, anterior cerebral artery, middle cerebral artery, it can cause stroke. Then in retinopathy, in ophthalmic artery, acute chest syndrome when it affects the chest. Then abdominal pain, gallstones, priapism. These are the acute complications. The complications can be because of chronic hemolysis, chronic anemia, or endovascular injuries. These includes avascular necrosis, bone marrow infarctions or osteomyelitis, septicemia, splenic infarctions. Also, it can lead to complications in pregnancy because of the hypoxia in the vessels. Now moving to the diagnosis. So for diagnosis of sickle cell anemia, we first sent a complete blood picture which showed anemia with reticulocytosis. There could be some icterus or jaundice in investigations. Peripheral smear, if patient is of sickle cell anemia or sickle cell disease, we can find sickle cells in these patients like shown in this. Yeah. So these are the sickle cells which we can see on peripheral smears of the sickle cell patients. There is a test called sickling test which we commonly heard during the camps or during screening of these patients. It is mainly used for screening of sickle cell anemia, which we will talk for this slide. Then diagnostic test is the HPLC or HB electrophoresis for hemoglobin variant analysis and genetic mutation analysis in cases where diagnosis is doubtful or not confirmed. So sickling test, what we do in sickling test is the purpose of this test is to detect hemoglobin S by inducing low oxygen conditions using sodium metabisulfate. So when we mix a drop of blood with sodium metabisulfate and cover it with slide, incubate for 30 minutes to 2 hours. When we examine in microscope, we can see sickle cells because of sodium metabisulfate reduces oxygen tension, causing HBS polymerization. So this is the test with we can screen sickle cell trait or sickle cell anemia. If sickle cells are present, which means HBS is present. If sickle cells are not there, likely hemoglobin S is not there. So limitation of this test is we cannot distinguish trait from disease. False negatives can be seen with recent transfusion or severe anemia, and confirmatory test is needed. So it is a good test for screening of sickle patients in high prevalent areas. Now moving to HB electrophoresis, which is the gold standard test for diagnosing sickle cells and sickle cell anemia, in which we look for HBS window. So whenever HBS is less than 40%, it is sickle cell trait, and usually F is less than 6%, and rest is A followed by A2. A2 will be normal in HBS. What happens in sickle cell homozygous? This we usually see HBS more than 50% with HBF. A2 will be normal or slightly high, and A will not be seen or seen in very trace amount. So in this, the HBS is around 87% with A2 of 3.4, F of 5%. Third is sickle beta thalassemia, which is also commonly seen in our population because of the high prevalence of thalassemia trait in certain population. So in this, HBS will be more than 50%, F will be like 5 to 35%, and A2 will be elevated. So the common question arises is whether we can discriminate sickle cell homozygous from sickle beta thalassemia on HPLC. So the answer is actually no. we have to do parental screening to see whether one of the parent is thalassemia trait or both are sickle heterozygous. Or if that is not feasible or parents are not available, then genetic testing is required to confirm the diagnosis of sickle homozygous or sickle beta thalassemia. So these are the different genotypes which we can see with sickle cell. So sickle cell anemia and sickle cell disease. So sickle cell anemia usually covers sickle homozygous and HBS beta 0 thalassemia, because these are a severe variety of sickle cell anemia. So in which rate of complication is high. Sickle HB beta plus thalassemia usually responds to some of the medications like hydroxyurea, and SC is not seen in India because of the prevalence of HBC. It is commonly seen in American countries. Moving on to complications. So there are different age groups in which complications are common. Infections we can see from any age group. There are certain complications like gallstones, kidney disease, or avascular necrosis, which increases with increasing age of these patients. Acute chest syndrome, asthma is seen in all age group of the patients. Then leg ulcers usually seen in older age population. Chronic kidney disease, chronic lung injuries seen in old age population. So initially what we see is ductilitis, which is commonly seen in infants or younger age group, followed by vaso-occlusive crisis. These crises, there are different crises which are mentioned in the books, like acute vaso-occlusive crisis, which is because of the sickling in the microvasculature of the joints, which causes excruciating pain. Then acute chest syndrome is one complication. Sorry. Then priapism, which is commonly seen in adolescent and adult age group. Retinopathy, which is seen after the adolescent or adult age group. Avascular necrosis in old age people. So yes, we do see a lot of tribal patients, and they tend to ignore these symptoms or signs and lead to an undiagnosis of these patients. So this is because tribal patients have milder complications or milder presentation of sickle because of very high prevalence of alpha thalassemia in these populations, which lead to higher HbF levels, which causes a lower experience of these symptoms like painful crisis infections and other complications of sickle cell anemia. So why we are talking of sickle cell anemia here? Because whether it can affect quality of life, yes, sickle cell anemia can affect quality of life. It is the quality of these patients are like cancer patients who are on treatment. So because of the high morbidity and mortality in older age group, it needs attention, and this is because of which the government of India is now also focusing on sickle cell anemia, and they have already implemented a program, National Sickle Cell Elimination Program by 2047, which we will be talking later on. So they have also noticed, there was a study in which they noted that those who have higher HbF levels and lower WBC counts have better quality of life than those, as opposed to the patients who have lower HbF and high WBC count. So this is what we commonly see in tribal populations, and it actually fits that higher HbF and lower WBC count improves the quality of life in these patients. Now moving to management of these patients. So there are certain non-pharmacological measures which we should educate the patient and parent about the sickle cell disease complications, treatment, and if there are potential cures of these patients. So they should maintain proper hydration, avoid extreme temperatures like extreme cold, extreme heat, avoid heavy exercises. They should have proper diet, including vitamin A, vitamin C, because these are antioxidants which helps in reducing the sickling in these patients. Also, there is no role of excess of vitamin C or E supplementation of sodium bicarbonate in routine management of sickle cell patients, which previously was attributable cause. So, as a pediatrician, they should be immunized along with the routine immunization. They should receive pneumococcal or meningococcal vaccines with annual influenza vaccines. Once they are vaccinated for pneumococcal and meningococcal vaccine, they should receive booster doses every 5 yearly of both these vaccines along with annual influenza vaccine. HIV vaccination is currently not recommended because after the age of 7 years, usually titers are maintained if they have received Haemophilus influenzae vaccine in the past. But yes, pneumococcal and meningococcal vaccines are required because of the hyposplenic or decreased splenic functions with the age. Moving on to the penicillin prophylaxis, which is actually indicated in patients with sickle cell homozygous to prevent the complication, to prevent the infections in these patients because of this. So, guidelines says they should receive oral penicillin twice daily, all HBS patients at least until 5 years of age. This is strong recommendation. All patients should receive oral penicillin at least till 5 years of age. We can stop after 5 years of age if they does not suffer from significant infections or life-threatening infections. HBSC and HBS beta plus thalassemias usually does not require penicillin prophylaxis if they are if they are not splenectomized. Pneumococcal vaccination should be uh, needed in all patients in all age group with sickle cell disease. And we should educate the families to seek urgent care if there is high grade fever. Because of high grade fever, because there are very high chances of going into the severe sepsis in these patients. So they should receive urgent care. Now moving on to screening, as we have already discussed that the complications of sickle which are life-threatening, like they can cause stroke, so that we can with transcranial Doppler starting from age of 2 years till 16 years of age, because the window the Doppler cannot detect flow after 16 years of age, and also chances of getting stroke is less after 16 years of age. So transcranial Doppler should be advised in all patients of HBS S or HBS beta 0 thalassemia. If the velocities are more than 200, then it is abnormal, and patient we might have to shift into regular transfusion program or exchange transfusion program. If PCD is between 170 to 190, we can try increasing the dose of hydroxyurea if it is improving. If it is not improving, then they are also candidate for transfusion program. All patients should be screened for retinal changes after 10 years of age annually, lifelong, to look for any evidence of retinopathy. If there is, then refer them to ophthalmologist for further treatment. Also, these patients have high risk of developing proteinurias, usually in older age group, but we should start screening at 10 years of age. If there is a proteinuria, then consult a nephrologist, and we should evaluate annually for the rising tide. So moving on to the treatment options, what are the treatment options available? So there is something called curative treatment option, and there is a pharmacological treatment. So initially we have four options available: hydroxyurea, voxelotor, Endari, or L-glutamine, or crizanlizumab. But recently, voxelotor and crizanlizumab have been removed from the list of treatment because of not showing either response to the treatment or with safety issues. So the option remains hydroxyurea or L-glutamine. Hydroxyurea is a longly tested drug, and which helps in most of our Indian sicklers because of the presence of alpha thalassemia genes and lower complications. Treatment options, curative treatment options include hematopoietic stem cell transplant, Lyfgenia, or gene therapy, which is currently not available in India. So we'll discuss this one by one.
Amit, we cannot hear you. Can you put your video off because your
Nucleotide
bandwidth might improve?
erythropoiesis of HB. So patients relations. Okay, okay. Ma'am, shall I start from here or go back? Hello.
Go back one slide.
One slide.
Yeah.
We
So
heard this.
moving. Okay, ma'am. So hydroxyurea, the mechanism of action is it inhibits ribonucleotide reductase, which helps in increasing stress erythropoiesis and HbF levels, thereby decreasing sickly in these patients and helps in improving vessel. Starting dose, usually what we recommend is start with 10 to 15 mg per kg per day and escalate every 6 to 8 weekly by 5 mg per kg. We can go up to 35 mg per kg per day or maximum tolerated dose by the patient. Common complications which we have encountered is myelosuppression, neutropenia or thrombocytopenia. If they develop neutropenia, thrombocytopenia, risk of infection is high. Rest all complications are usually not encountered in Indian population. Then crizanlizumab. Hello. Am I audible?
Yes.
Yes. Then crizanlizumab. It was actually approved in 2017 as a P-selectin monoclonal antibody against P-selectin. It decreases leukocyte adhesion, one of the mechanism causing complications like endothelial injury. So it helps in improving that complication. It was initially approved at a dose of 5 mg per kg per day with limited side effect, but it was withdrawn recently because of not showing not showing any efficacy in these patients. Oxalator, it binds to HBS and stabilizes the oxygenated state, thereby decreasing polymerization and helps in reducing hemolysis and anemia. It was also approved uh, uh, for more than 12 years of age, the dose we have mentioned, but it has been withdrawn due to safety issues. L-glutamine, which is actually
Dr. Amit, your voice is breaking.
increasing glutathione will close safety diet is usually not okay. Ma'am, let me know if it is better. Hello.
Yes, now it is better.
Okay. Okay. So L-glutamine alone is not helpful in sickle patients. We can use in combination with hydroxyurea to improve the efficacy of hydroxyurea. These are all common complications which we encountered in sickle cell patients like vaso-occlusive crisis, the treatment of which is hydration, analgesia. Acute chest syndrome usually manifested as chest pain, cough, hypoxia, fever, and new infiltrates on chest X-ray, the treatment of which is oxygen, antibiotics, and sometimes transfusion. Stroke, it is one of the dreaded complications. And once they develop stroke, the patient usually requires exchange or simple transfusion for prevention of further stroke. Splenic sequestration, whenever a patient comes with sudden onset uh, anemia, hypovolemic shock, and increase in spleen size, it is the first differential at that time, and these patients require urgent transfusion to improve the volume. And if they develop these life-threatening complications, they are also candidate for shifting to transfusion program or exchange transfusion. Aplastic crisis, which is mainly due to parvovirus B19 infections, and it needs supportive care in form of transfusions. avascular necrosis, it needs physiotherapy, pain control, and orthopedic consultation. And pulmonary hypertension usually develops in those patients who have chronic anemias. So these are also a candidate for transfusion program, but under monitoring. So for pain management in vaso-occlusive crisis, we have different options available. Most of the patients usually respond to paracetamol. We usually avoid brufen or meftal in these patients because of risk of endothelial injury. Codeine, tramadol, morphine can be tried these patients based on the intensity of pain. Now moving on to indications of transfusion. So the indications of putting into exchange transfusion or simple transfusion. The funda behind simple transfusion and exchange transfusion is that if patient is maintaining hemoglobin around 9 to 10 gram percentage, then they are the candidate for exchange transfusion. Those who are not maintaining adequate hemoglobin, then they are the candidate for simple transfusion. Any patient who develop syndrome, aplastic anemia due to parvovirus B19 infections, clinic sequestrations, or hepatic sequestrations. Usually, transfusion helps in these patients. Those who develop stroke, they should be put on regular transfusion program so that the risk of having recurrent stroke is less. Now, moving on, indications of HSCT. So currently, not all patients in India require transplantation. There are certain indications in which transplant is indicated, like if patient, all those indications in which patient is required, patient needs to be shifted to regular transfusion program like stroke, repeated acute chest syndrome, clinic sequestrations. These are the candidates in which transplant is beneficial. So according to American Society of Hematology guideline, if there is match-related donor present and the patient is having word stroke or abnormal TCD, they are the candidates for uh, transplantation. Those who develop frequent pain, panel recommends if there is match-related donor available, then they can consider transplant in these patients. Also, those who develop recurrent acute chest syndrome, match-related donor is available, then they prefer transplant over standard care. For those sickle cell disease patients needing hematopoietic stem cell transplant and not available, and they do not have match sibling donor available, then alternate donor transplant should be in clinical trials or after discussion with the parents. This is what is the now era is coming of gene therapy. This is there are two gene therapies available, FDA approved in India. FDA approved gene therapies, which are currently not available in India. The methods are either gene addition or gene editing. Gene addition is when we introduce the healthy gene from a donor. And gene editing is when we use certain technology called CRISPR-Cas9, in which the affected gene is edited with this technology. So both of these are FDA approved with more than 90%, more than 90% success rate with reduction in complications. The only issue is the cost. Cost is around 3 million US dollars, which is actually not for the, which is a, sorry, which is actually not to the reach of Indian patients. So there is this gene editing is a CMC Vellore has already started for hemophilia patients and they have shown good results. They treated 5 patients with 5% of hemophilia and they found that all 5 patients are now free of bleeding manifestation. Now, what the government has implemented National Sickle Cell Anemia Elimination Mission. So, in which their vision is to eliminate sickle cell anemia as a public health problem by 2047. And their mission is to improve care, reduce the prevalence of disease through screening, awareness, and management strategies. The target population is 0 to 18 year initially, and they will expand up to 40 years of age. And their focus is on 7 high priority states: Gujarat, Maharashtra, Madhya Pradesh, Odisha. This is actually what we call sickle belt, in which prevalence of sickle cell anemia is very high. So their strategy is to uh, to make awareness and premarital counseling in these patients, prevention by universal screening and early detection, and care to all these patients who are suffering from sickle cell anemia. So primary prevention is by individual and community awareness, the involvement of uh, different workers at different levels, school outreach programs, counseling at primary and secondary healthcare with healthcare workers. They have partnered with National Health Mission along with RBSP and collaboration with Ministry of Tribal Affairs, along with many NGOs. And they are using IEC and mass media to promote these missions, also using social influencers to promote these policies in different sectors of the. So, thank you. So there are certain questions which Anjali madam has put regarding neonatal screening. So they have already implemented the project uh, in the in high risk population, in high risk sectors of India. So in which what they were doing is they screen all the pregnant women in high risk endemic areas, and if they found that the pregnant woman is suffering from sickle cell anemia, then they test the spouse. If the spouse is also suffering from sickle cell anemia, then they test the neonate at birth at 6 weeks and at 6 months of age. If the neonate is suffering from sickle cell anemia, then they start folic acid supplementation at 6 weeks of age, immunization with pneumococcal vaccines at 6 weeks of age, and they counsel the family about disease awareness, complications, and need for hydroxyurea to start at 9 months of age. So, hydroxyurea actually is FDA approved by 2 years of age, but based on the baby up study, they found that after 9 months of age, we can safely start hydroxyurea. And there are studies going on in which they are trying to start hydroxyurea at 6 months of age. The basis of starting hydroxyurea early is to reduce the complications, and also mainly the organs which are affected by sickle cell anemia to reduce the complications of these affected or complications in these affected organs. And one more question was asked: is universal HB electrophoresis testing for all pregnant women is good idea? Yes, ma'am. So government is actually planning to start this program, especially in high endemic areas. Not HPLC, but CBC with HPLC or HB electrophoresis is needed, because if iron deficiency anemia is predominantly iron deficiency anemia is seen in around 60 to 70% of women in our country, and most of these women belongs to lower socioeconomic strata. So with iron deficiency, there is chances of missing thalassemia trait, not sickle cell anemia, but thalassemia trait can be missed in overtly iron deficient women. So CBC and HPLC or iron deficiency, HPLC or electrophoresis should be performed hand in hand. If anemia is there, we should correct the anemia and repeat electrophoresis. For sickle cell anemia, uh, iron deficiency or vitamin B12 deficiency usually does not affect HbS levels. Yeah. Thank you.
Anybody is having questions?
All queries solved.
No, there are more questions.
Maximum dose of hydroxyurea.
So, as per guidelines, up to 35 mg per kg per day, we can go up. But there is a chances of going into neutropenia and thrombocytopenia. So maximum dose is based on the maximum tolerability of the patient. If patient is developing cytopenias at 25 mg per kg per day, then we should go down to 20 mg per kg per day if they are tolerating. So that actually depends on the tolerability of the patient.
And what would be the interval for regular transfusion in sickle cell? Those who are candidates for that?
So, ma'am, that depend. It is, ma'am, it is not like thalassemia. We should
Yeah,
aim at 10 gram per kg, 10
yeah.
gram percent of hemoglobin. We should maintain hemoglobin less than 10 gram percent, around hematocrit of 30%, because higher
Okay.
hematocrit can cause complications in these patients. They have high risk of stroke. So because
Yeah.
of which we should aim hematocrit of around 30%, not above that.
Thank you. Thank you so much.
Thank you, Amit, for a wonderful presentation.
Thank you.
Thank you, Dr. Amit. Now we'll go for our next topic. Dr. Manohar Patil from Virar, he's pediatrician from Virar, is going to present 3 interesting cases in pediatrics. So I request Dr. Manohar Patil to go ahead with the topic and the cases. Dr. Manohar?
Manohar was there.
हाँ गुड आफ्टरनून मॅडम.
Good afternoon, Amit. Welcome back. Come on.
हा मॅडम ते म्यूट केलेलं तिकडून म्हणून.
अच्छा अच्छा.
माझ्या 3 केसेस आहेत मॅडम. तिघही सिंपल आहेत पण डे टू डे प्रॅक्टिसमध्ये युजफुल आहेत. ते मला वाटतं की युजफुल होतील म्हणून मी ते प्रेझेंट करतोय.
Okay.
हा.
Sir, try sharing now.
येस 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 आय एम डुईंग.
Your second ID was not co-host. Now it is there.
Two devices आहेत का?
हो हो एक मिनिट. हा इकडून होत नाही मॅडम शेअर. ऍक्च्युली काय होतंय. मॅडम ते एक मिनिट.
Pallavi ma'am, can you help Manohar?
हाँ सर मॅम करते
त्याची स्क्रीन शेअर होत नाहीये बघ.
हो मी करते मॅम. मनोहर सर फक्त शेअर बटन वर क्लिक करा.
नाही होते क्लिक नाही होते.
तुमच्या इथल्या शेअर बटन वर क्लिक नाही होते.
नाही.
ग्रीन कलरचं जे बटन आहे ते.
हो नाही होते मॅडम.
मग सर तुमच्या झूमचा इश्यू आहे. सेकंड तुम्ही लॉग इन केला होता आयडी त्याच्यावरून करता येईल का?
एक मिनिट. मी एक मिनिट.
हो सर.
हा आता एक मिनिट.
तुम्ही आता आहे ना तुमचं पीपीटी ओपन करा.
हा झालं मॅडम.
त्याला फुल स्क्रीन करा. येस सर मेक इट फुल स्क्रीन.
Yeah,
आता
we can see
दिसतंय.
Manohar.
Yes.
Manohar, we can see your slides.
Yes sir, it is full screen. Kindly start. Thank you.
Good afternoon everyone. First case, 3 months 29 days, 6.2 kg male, came with history of high grade fever only since morning. On the day of presentation, I treated him like a viral infection only, but baby was having high grade fever, intermittent grunting and frightened episodes, and irritable while micturating. So I did urine routine that came normal. Baby was full-term normal delivery and bottle fed. On examination, baby was 101.4, toxic looking, grunties was there, इंटरमिटंट म्हणजे दचकतो असं त्यांचं म्हणणं होतं बेसिकली. RS वाईज नॉर्मल, CVS नॉर्मल, पल्स वॉज 167. In CNS finding, he was irritable. Abdomen normal. On second day, the baby came again with same history. So I advised hospitalization. Baby was hospitalized and investigation sent, which was hemoglobin was 9.4, WBC 9,700, platelet 4 lakhs 12 and 12,000, CRP was 5, ESR 14. As the baby is only
Platelets
3
were
months,
4 lakhs or 41,000.
4 lakhs 12,000, sorry.
Okay.
Procalcitonin was negative as baby was only 3 months 28 days, urine was normal. So I did procalcitonin. SGOT, SGPT normal, chest x-ray was normal. As baby is paraneonate, I have started empirical antibiotic ceftriaxone and symptomatic medicine. From history and clinical presentation, it looks like viral infection and high-grade fever. But I counsel the parents that we may need to do CSF, lumbar puncture, and parents were immediately agreed to do the CSF, and CSF was done as irritability was there during fever spikes, and the CSF shows 350 cells on day 2 of hospitalization within 24 hours with neutrophils 83%, lymphocytes 17%, protein 58, sugar 47, random sugar was 89, and it shows gram positive cocci. I was shocked. Within almost 36 hours of fever spike, I did the CSF and it came 350 cells. Then I sent CSF culture and along with that I sent biofire also, and that came Streptococcus pneumoniae positive. So I took neurologist opinion, and she advised me that start injection Dexa along with injection vancomycin, and it is a gram positive cocci, and CSF biofire is suggestive of Streptococcus pneumoniae. That's why I added along with monosep Dexa and vancomycin. Dexa given for 3 days. Clinically, patient becoming better, fever subsided, but intermittent he was lethargic for next 2 to 3 days, and there was intermittent jerky movements during sleep, and occasional steering loop was there, but there were no as such clinical convulsions or seizures episodes. MRI brain was done on day 4th. That was almost normal. CSF culture, no growth. Clinically, baby improved. The repeat CSF on 6th day, the WBC count is only 3 cells, and all were lymphocytes. Protein 22, protein is from 58 to 22. It is reduced. Sugar is 52, along with random blood sugar 104. The and CSF culture was normal. The clinically patient improved. The final diagnosis is bacterial meningitis because of Streptococcus pneumoniae. In this case, the blood culture didn't come out positive. Your CSF culture negative. What helped me to detect the organism is CSF routine. That is gram positive cocci and CSF biofire. Total 14 days of IV antibiotics given. There is no neurological deficit. Recently, I did the Bera test. That is also normal. The take-home message from this case is early diagnosis is the good outcome. Procalcitonin and CRP may come negative in bacterial meningitis. Case number 2.
Manohar, just a question. Was this patient vaccinated for pneumococcus?
Yes, madam. At government center, 1.5 months vaccine was given. I
Yeah.
saw the record.
Just whether, yeah, of course, this will not mean that it was a immunocompromised host.
Yes, yes. I have planned to take a immunologist opinion. I already counseled the parents because that was very stranger for me that already proper immunization was done. Just he was planning to go for 2.5 months vaccination, and he developed high grade fever. But the parents were very cooperative. That's why it is possible to do CSF in 24 hours and diagnose the case of meningitis.
Excellent. Excellent, Manohar.
Second case,
थांब
10 year.
थांब
हा.
2 टेक होम मेसेजेस.
येस सर.
अडचण आली की मनोहरला विचारा.
अरे नाही सर.
दुसरा, माझ्याकडे बेन्झाईल पेनिसिलिन नेहमी असते.
ओके सर.
नाही, बेन्झाईल पेनिसिलिन इज क्वीन ऑफ अँटीबायोटिक्स. इट वर्क्स इन 4 hours. अदर मेडिसिन्स टेक 48 hours.
येस
सो
येस.
ते तुम्ही व्हँको वगैरे सगळं द्या, पण बेन्झाईल पेनिसिलिन जरूर द्या, माझ्याकडे मिळेल. सगळ्यांसाठी सांगा.
येस सर. ऑलरेडी आम्ही एकदा वापरलेलं. मी अंकुरला असताना एक याची केस होती आपलं कंजेनायटल सिफिलिस.
आय नो.
हा येस, तेव्हा वापरलेलं. त्याला बाळाला दिलेलं आणि मदरला पण आपल्याला द्यायला लागलेला. येस.
आता कुठे मिळतंय सर बेन्झाईल
माझ्याकडे आहे.
पेनिसिलिन?
आज माझ्याकडे
अच्छा.
आहे. नंतर डिटेल्स तुला मी पत्ता देऊन टाकेल.
अच्छा.
सगळ्यांना देईल, ऍक्च्युअली ग्रुपवर टाकून देईल.
आता चॅट बॉक्स मध्ये क्वेश्चन आहे की वाय डेक्झा.
डेक्झा टू डिक्रीज द सेरेब्रल एडिमा.
ओके.
ऍक्च्युली
It has to-
डेक्झाचं तेच होतं की आय टॉक टू न्यूरोलॉजिस्ट डॉक्टर निलिमा नारखेडे मॅडम, की मॅडम हे तर एच इन्फ्लुएन्झा नाहीये, तर मग डेक्झा का? तर तिथलं जे सेरेब्रल इरिटेशन आणि सेरेब्रल इडिमा जे आहे ते कमी करण्यासाठी डेक्झा विल हेल्प. सो डेक्झा वॉज गिवन.
किती वेळ? एकच दिला का 2-4 दिले?
नाही सर. प्रॉपर 3 days. 8 hourly doses. 0.15 milligram per kg per dose every 8 hourly for 3 days.
And one more question chat box, why CSF repeated on day 6?
It is advised by a neurologist, and whether we are going on the right track or not. That's why.
Okay.
Even MRI was did for parents' concern only on the day 4th. They were persistently asking की सर मेनिंजायटिस आहे, एवढं इन्फेक्शन आहे, आम्ही सगळं इंटरनेट शोधून काढलं, तर हे तर खूपच डेंजर आहे. तर MRI पण करतात याच्यामध्ये, म्हणून MRI केला.
मनोहर सफर फ्रॉम पेरेंटायटिस. बरं, स्ट्रेप्टोकॉकस निमोनिया पेनिसिलिन सेन्सिटिव्ह आहे का रेजिस्टंट आहे? फ्रॉम युअर जनरल नॉलेज एनीबडी कॅन आन्सर दिस.
सेन्सिटिव्ह.
कधीच रेजिस्टन्स नाही आहे का त्याला?
ऑलमोस्ट नाही सारखंच आहे सर. इवन न्यूरोलॉजिस्ट जे असतात, पेडियाट्रिक न्यूरोसर्जन, दे प्रेफर पेनिसिलिन ग्रुप.
बरोबर, ठीक आहे. माझा काहीतरी अनुभव सांगतो की आम्ही गेल्या एवढ्या वर्षात जितक्यांदा पेनिसिलिन वापरलं ना, त्या 100% वेळा ते सेन्सिटिव्ह आलंय. नॉट वन फेल्युअर इन मेनी इयर्स.
सर फक्त ते पेनिसिलिन ग्रुप ऑफ ड्रग आहे ना, त्याला लोक घाबरतात, कारण त्याचे प्रिव्हियसली जे सेन्सिटिव्हिटी रिॲक्शन जे आलेले आहेत, ज्याच्यामुळे जे लोक किंवा किड्स सफर झाले आहेत, एक्सपायर झाले आहेत, त्यामुळे.
नाही, आपण अनाडी आहे. पेनिसिलिन इज एम्पिसिलिन. पेनिसिलिन ज्याला सेन्सिटिव्ह सेफलोस्पुरिनला पण आपल्याकडे मोनोसेफ्ली मेलेले आहे विथ लोक.
हो.
इशू नाही. आय एम नॉट कमेंटिंग अबाउट एनीबडी. जस्ट आय वॉज लर्निंग फ्रॉम यू ऍक्च्युअली. जस्ट लर्निंग. आय एम ग्रेटफुल, हॅपी अबाउट यू, प्राऊड ऑफ यू. छान.
थँक्स.
You saved a life. You saved a life. He would have been handicapped or whatever. Delay would have handicapped you.
Yes, sir. Yes, definitely.
Well done. You get one Kalingad from me today.
Okay, sir. Thank you. My next case is 10-year-old, 4 months male, came with high-grade fever since 5 days. He was lethargic. On examination, toxic loop was there. He was vaccinated. Each and every vaccine was taken by that kid. Almost all vaccine, including pneumonia, pneumococcal vaccine. On examination, 101 fever, poor oral intake, dehydrated. RS was clear, CVS normal, CNS normal. Just liver was there, that was tender, 3 centimeter. I advise admission, hospitalization. investigation sent, hemoglobin 12.6, WBC count 9,710, neutrophil 71%, out of which platelet was 2,05,000, CRP 109, ESR 36, SGOT was 115, SGPT was 62, urine routine almost 10 to 15 per cells. There are multiple thought processes in this case. I have started injection ceftriaxone and symptomatic treatment. Response to treatment was query. There was persistent high-grade fever, but there was a strongly positive report on day 2 that it is suggestive of typhoid. That is, type O is 1:320, type EH is 1:160. That is suggestive of typhoid almost. Then I asked the parents about vaccination. That baby received three doses of typhoid vaccine, 2 from my side and 1 from government. After 2 years, there is no vaccination at our place in our card. That's why he received typhoid polysaccharide vaccine also, typhoid conjugate vaccine also. I thought at that time that the chances of typhoid is almost nil, but the blood culture grew to Salmonella typhi. Then patient was febrile till almost 7 days of hospitalization. The patient became asymptomatic on discharge on 7th day with IV I continued the IV antibiotic ceftriaxone for 14 days. But just one, I asked my friend, Dr. Keyur Mehta, he is infectious disease specialist from Pune, the same case. He was very surprised about this case, whether he take a gutter's water to drink the water, because 3 doses of typhoid received by that patient till Salmonella typhi is showing in the blood culture. It was very surprising to me also and parents also. Take home message: in spite of complete vaccination, typhoid can be positive. This is my second case.
Yeah. So, Manohar, was there
Yeah.
any history of this patient having consumed anything outside a week or 10 days earlier? Because,
Yes. He was attended 2 to 3 marriage ceremony
yes, because
in
a
the
large
remote
dose,
places.
yeah, a large infected dose can still give typhoid because it is not, it is bacterial load dependent. So, in spite of
Yeah.
taking vaccine, we cannot go around drinking unsafe water. We have to be very, we have to still counsel them about that.
Yeah. Even I had a patient who was vaccinated and was Salmonella typhi positive.
Yes.
So, so
I
we
would
Madam,
like to discuss epidemiology of typhoid after Manohar's presentation.
Even we
this
had a typhoid, Salmonella typhoid
No, I
positive
am
case.
talking about resistant typhoid now. 3 cases of resistant typhoid I would like to talk.
and almost this is the 4th case I have seen that is vaccinated for that typhoid TCV, conjugate for typhoid vaccine. So whether the single dose we should continue in IAP schedule or we should implement second dose at 5 years of age will help to prevent the further episodes. That is query. My
The
third case, yes sir.
query is remaining undergraduate.
Nahi,
Saying that I have seen 4 patients having typhoid twice, so give 2 doses is postgraduate consultant. That is the only difference. The first resident said, "Is this TB?" The lecturer says, "Is it TB?" The boss says, "Yes, it is TB." There is no difference. Boss doesn't know anything more than the younger people. You have to become confident and then say, if I have seen 4 patients, then you need to give 2 doses.
sir, but uh, I talked to Dr. Tanu Singhal madam 4 years back that whether we should continue the same vaccination that was previously implemented 2 doses schedule. Uh, she said 1 dose is sufficient. Why to invest on second dose? So that's why I told query.
I got. Why we give 2 doses of MMR and whatever
Three,
vaccine? Whatever.
doses.
That's what I'm saying.
Because,
Why? Because somebody else said it.
yes,
But
yes.
I'm proud of you. You got 2 Kalingas.
Thank you, sir.
Uh,
The third case is
Manohar,
uh,
just a small thing. They
sir.
should take 1 or 2 doses, but always have cooked food outside, boiled water, and all precautions to prevent typhoid and other waterborne illnesses.
Yes, madam, definitely. My third case is 7 year 8 months male, weight 21 kg, fever on and off since 20 days. That fever intensity is increased since last 2 days. Appetite is decreased. There is a weight loss of almost 2 kg. The patient is from Sapade, received treatment from local doctors, and intermittently he was all right. The investigation wise, I have admitted the patient. The investigation said the hemoglobin was 13, WBC 9,300, neutrophil 37, lymphocyte 55, platelet was 375, CRP was 4, ESR 18, SGOT 71, SGPT 68. Vidal negative, blood culture negative after 3 days. Primary blood culture is negative. Uh, what is the thought process in this case?
With hemoglobin so high, dengue fever?
No.
सांगून टाक. आम्ही नापास.
Detail history taken, blood culture, no growth after 1 week. Patient was febrile till 4th day. History of fever since 20 days. So I sent Brucella IgM test. But patient was improving on ceftriaxone. Brucella came positive. Then patient was almost febrile for on 5th day. I counseled the patient relative that it may be something else, that Brucella test is positive. We need to take in that way treatment. Then the relatives are arguing that he is improving now and accepting food well. Then why to go ahead? Just we will continue 2 to 3 day injections, and then it will be okay. Then I advise them to take Madam Tanu Singhal Madam's opinion. Madam took proper history and all investigations, so and asked me, it may or may not be Brucella. Then she sent Brucella IgM, IgG, and Brucella tube agglutination test. That all come positive. So the treatment started, that doxycycline and rifampicin and ideal doses, because it is the child is almost 8 years old. That's why doxycycline and rifampicin started. And I advise to grow blood culture in extended and 10 days. That also shows Brucella species. Then I already asked the history to parents whether he was consuming the raw milk. The relatives and parents was that just that tabela milk he was intermittently consuming, but it was boiled. Tanu madam was also surprised that how it can possible, because he was not accepting raw milk and there is no clinical feature suggestive of brucella. I did sonography to look for the splenic micro abscesses that can we can see in the brucella also, but it was almost not seen in the sonography. So in this case, take home message, even boiled milk can cause brucella, and it may transiently respond to the ceftriaxone, what we generally use to give for 5 to 6 days of fever. Thank you.
छान झालं.
Ideally,
3 कलिंगड.
ideally pasteurized milk should be used.
Yes, yes.
No boiled milk, no boiled, only pasteurized milk only.
Anuradha, what is
Yes, sir.
pasteurization?
Pasteurization usually
मी सांगतो.
बर
स्वयंपाकघरात दूध गरम करून थंड करतात, त्याला पाश्चरायझेशन म्हणतात. त्यांना ते माहित नव्हतं. ते पाश्चर नावाच्या माणसाने आपल्याकडे बघून करून दाखवलं आणि त्याला आपलं नाव दिलं. पाश्चरायझेशन 85 डिग्रीला तापवतात. आपण बॉईल करतो तेव्हा 121 डिग्रीज होते.
पण ते
त्याचा
पाश्चरायझेशन मध्ये सडन बॉईल करतात आणि ते सडनली रिड्यूस द टेम्परेचर.
काय नाही गरम करतात आणि फ्रीज मध्ये ठेवतात, काय करत नाही. मी अभ्यास करून सांगत आहे, मी अभ्यास करून बोलत आहे. आपल्या लोकांना इंग्रजी येत नाही आणि खोलात जात नाही, त्यामुळे आपली वाट लागलेली आहे. फक्त पाश्चरायझर नाही म्हणून ब्लड बँक ब्रेस्ट मिल्क बँक होत नाही. पाश्चरायझर म्हणजे नुसतं दूध गरम करून थंड करणं एवढंच आहे. तुम्ही जर गॅसवर गरम करून फ्रीजर मध्ये ठेवलं तर पाश्चरायझेशन होऊन गेलं. आय एम व्हेरी सिरियसली म्हणजे व्यक्तिगत नाही आहे,
ओके
काय
सर.
आपण खोलामध्ये जात नाही अगं.
ओके.
पाश्चरायझेशन म्हणजे दूध गरम करून थंड करणं एवढंच आहे. फक्त जर पाश्चरायझर म्हटलं की कोटी भारतीयांना
नाही,
कळत
आपलं तनुज सिंगल मॅडम पण तेच म्हटलं की ऑलरेडी ते आर बॉइलिंग द मिल्क, द चान्सेस आर व्हेरी लेस.
नाही त्यांच्या घरी आहे का गाई म्हशी?
हो सर, सपाळ्याचं पेशंट आहे, सपाळ्याचं पेशंट
नाही
होतं.
नाही त्यांच्या घरी गोठा आहे का?
नाही
ते
नाही
माहित
नाही
नाही. हा.
नाही.
काय आहे की आता कालच yesterday only we attended, I'm not getting it. काल समीर शेखनी सांगितलं की तुम्हाला करायची गरज नाही, घरात कोणाला पण असलं तरी तर तुम्हाला ते होऊन जाते. तू होता का काल तिकडे? समीर शेखने सांगितलं ना, ब्रेस्ट मिल्क
हा हा
सीझर
हा, येस येस येस,
सीझर
आय वॉज
केलेला बाळ आणि आईच्या नॉर्मल डिलिव्हरी दोघांच्या बॅक्टेरिया सेम असतात.
हा, येस येस
तसं दुसऱ्या बाळाला असेल तरी ते होऊन जाते सेप्सिस. यू डोंट हॅव टू बी सेम. त्या आपल्या एका रूम मध्ये सॅल्मोनेलाचा पेशंट असेल ना, तर अख्ख्या रूम मध्ये सॅल्मोनेला असतो, त्याचं दूध प्यायची गरज नाही तुम्हाला असं. पण आय एम हॅपी अनुराधा, गुड युअर म्हणजे आपण चर्चेमधनं छान निघतं म्हणजे. आणि
येस.
वी आर हॅपी. शिष्यात इच्छित पराजय. पहिले शैलेशच ग्रेट केसेस करायचा, आता मनोहर पण करायला लागला.
नाही हो सर,
वी
साध्या
हॅव
केसेस
प्राऊड
आहेत.
ऑफ यू. छान आहे.
जर ललित नसेल तर मी माझे 3
हो.
ललित, यू आर देअर?
शैलेश
या.
तो भरत काहीतरी सांगतोय. सांग भरत, सांग.
हा, मला काय म्हणायचं होतं, पहिलं जे मनोहर बोलत होता ना, इरिटेबिलिटी अँड फ्रायटन, इट मे बी अ टॉनिक कन्व्हल्जन्स.
येस.
Maybe tonic convulsions, we miss that because I have seen in Sion Hospital, because it was tonic convulsions and repeatedly it comes, means it can be conclusive of meningitis. Okay. For
Yes.
second thing, then we give Dexa, not for the cerebral edema also, but to prevent the deafness, not only in H. influenza but even in streptococcus also. The second case was what sir says, Hemant sir, की आपण पॉच्चरायझेशन करतो. when we in GS in RA and Worli Dairy, must be even Shailesh Bharat must be knowing. There what they say, you have to be, whatever is told की it is up to म्हणजे 120 डिग्री पर्यंत, परंतु 20 मिनिटं बॉईल करायचं, थोडं थंड करून नंतर फ्रीज मध्ये ठेवायचं. डायरेक्ट फ्रीज मध्ये ठेवलं तर ते दूध फाटतं. पण ते लुईस पाश्चर म्हणतात, बरोबर आहे सर बोलतात, ते पाश्चर नावाचा माणूस आला, त्यांनी हे केलं, सांगितलं. आणि हे तबेलाचे लोक काय करतात, जसं आपल्याकडे लोक येतात की आरओचं वॉटर आम्ही पितो, पण आपण सांगतो की आरओ वॉटर डझंट किल द बॅक्टेरिया. आणि बिफोर सर काय सांगणार की रेजिस्टंट टायफॉइडचे 3 केसेस. पहिलं चीज म्हणजे तुम्ही 3 वॅक्सिनेशन दिले, पण राईट फ्रॉम एअरपोर्ट टू द वॅक्सिन डिस्ट्रीब्युटर टू अवर सेल्फ, कोल्ड चेन मध्ये पण प्रॉब्लेम असेल तर इवन आय हॅव सीन की our given polysaccharide or whatever vaccine, then also you get a typhoid also, because cold chain is also most important. Manohar, बरोबर ना? हेमंत सर, तुम्ही सिनियर आहात, तुम्ही बोला.
हो, मेरा भारत महान, एकदम बरोबर आहे.
बरोबर आहे ना? कोल्ड चेन
एकदम
पण
बरोबर.
मेंटेन नसेल तर बरोबर आहे.
हो.
आणि आपल्या फ्रीज मध्ये आपण काय पाण्याच्या बाटल्या काय ठेवतो, टेम्परेचर मेंटेन होते की नाही माहित नाही, ते पण आणखी ते एक
शैलेशनी
आपलं लॅक्यून आहे.
हं.
अंजली मॅडम
शैलेशनी
पण
करून
त्याच्यावरती
ठेव.
सांगतील, अंजली मॅडम पण, कारण तो पण
मी
इम्पॉर्टंट
पण
पॉइंट आहे.
सांगणार आहे. मी पण सांगणार आहे.
हा
शैलेशनी स्पेशल फ्रीज करून घेतला आहे, मेड टू ऑर्डर. तसा आपण
हा,
करून
मेड टू
घेऊया.
ऑर्डर आमच्याकडे, माझ्याकडे आणि अशोक शुक्लाकडे पण आहे तो फ्रीज मेड टू ऑर्डर, आम्ही बनवून घेतलाय खास फक्त वॅक्सिन साठी.
बरोबर, आम्ही तुमचा बघायला येऊ आणि शैलेशचा पण बघू, आम्ही सगळे म्हणून
नाही,
घेऊया.
आम्हाला तुमच्याकडे पण यायचं. त्या दिवशी संडेला नाही आलो उपडी पाहायला आम्ही, नंतर येतोच तुमच्याकडे.
आहे. या बोंबील काढून ठेवतो या फ्रीज मधून.
चल शैलेश, कंटिन्यू.
हा, एक मिनिट, मी टायफॉइडची गोष्ट सांगून देतो ना. एक आमच्याकडे आता नवीन एक लोकम असतो, ओंकार म्हणून. त्यांनी DNB केलाय बॉम्बे हॉस्पिटल मधून. तर बॉम्बे हॉस्पिटलला त्याचा थिसिस होता, स्टडी ऑफ इंडोर ऍडमिशन ओव्हर 1 year. तो बॉम्बे हॉस्पिटलच्या सर्वाधिक तापाचे पेशंट टायफॉइडचे होते. एक डॉक्टर आहे शिवप्रकाश म्हणून, तो आता प्रेसिडेंटला इलेक्शनला उभा होता IAPच्या, तो हरला तो साऊथचा. पण त्याचा MDचा थेसिस होता स्टडी ऑफ 12,000 स्टुडंट्स ऑफ 11th and 12th स्टँडर्ड ओव्हर 1 year. तर तो म्हणे जे जे लोक मागे पडले करिअरमध्ये 11वी 12वीला, त्यांना 1 महिना टायफॉइड होता म्हणून ते मागे पडले. मग माझ्याकडे थोडी जुनी गोष्ट सांगत तुम्हाला, दोन चार गोष्टी सांगतो टायफॉइडच्या. जॉन 23च्या एका टीचरचं एक मुलगी आमच्याकडे ऍडमिट झाली, टायफॉइड निघाला. मग त्याला म्हटलं सगळ्यांना व्हॅक्सिन दे, त्याने ऐकलं नाही. मग दुसऱ्या मुलीला टायफॉइड झाला, पुन्हा सांगितलं सगळ्यांना आता व्हॅक्सिन द्या, त्याने दिलं नाही. मग तिसऱ्या मुलीला टायफॉइड झाला, मग आईला टायफॉइड झाला, मग बाबाला पण टायफॉइड झाला. सो तुमच्याकडे टायफॉइडचं बाळ आलं ना, तर पूर्ण फॅमिली. झालं माझं सांगून. थँक्यू.
ललित आहे क्या?
शैलेश तू बोलून होता.
4:30
असेल तर मी 2च मिनिटं फक्त मला बोलायचं आहे.
त्यांचे 4:30 पर्यंत मीटिंग होते.
सो मी आता
आता 4:07 झालेत. बोल.
गेल्या 1 महिन्यामध्ये ना मी एंटरिक पॉझिटिव्ह 3 सेफ्ट्रॅक्झोन रेझिस्टंट टायफॉइड बघितलेत.
बरोबर.
त्यातला एक आहे तो 10 वर्षाचा एफ्लुएंट क्लास, म्हणजे विरार मधले पहिले 2-3 जे आहेत त्याच्यातलं एक आहे, अँड व्हेरी एज्युकेटेड, आणि त्याला साल्मोनेला टायफी पॉझिटिव्ह होता. 14 days ऑफ IV सेफ्ट्रॅक्झोन दिलं गेलेलं आहे फुल डोज मध्ये, 100 मिलीग्राम पर किलोग्रामचा डोज मध्ये 14 days दिल्यानंतर 15 दिवसांनी त्याला परत फीवर आला. And we thought that it might not be typhoid, but then we repeated the culture and it turned out to be typhoid. The first time when he was admitted, he had a azithromycin resistant typhoid fever, which is a very rare but a very dangerous species, because he did not respond this time to ceftriaxone or any other thing. We had to give Ceftran. He did not respond to ceftriaxone, but the second blood culture when we sent, the azithromycin sensitivity was checked not by disc diffusion but by other method at Hinduja Hospital, and it turned out to be positive. He is on azithromycin and he is responding now. So that's a resistant typhoid, relapse of typhoid, which was treated completely for 14 days of IV antibiotic religiously. That is my first case. So beware of typhoid and don't half-heartedly treat them. You may end up in problem. And these parents were very nice and they were very friendly with me. That's why the things are in a good shape. The second case I'm talking about is a typhoid which was a 13-year-old child, admitted, 50 kg weight, admitted, turned out to be typhoid, which was ceftriaxone resistant typhoid. Ceftriaxone we could not give. Fever was 104 with severe abdominal pain. We started on meropenem full dose. 2 gram TDS meropenem started with a good brand. It was not that some stupid brand of some stupid company. Good brand meropenem was given for 7 days. The fever did not respond. We had to take opinion of infectious disease Dr. Tanu Singhal madam, and it was then switched over to, this child was also azithromycin resistant. It was switched over to Ceftran, double dose Ceftran, and that child responded after 5 days of Ceftran. And now he is better. We completed 10 days of Ceftran, but then this child was Salmonella positive, azithromycin and ceftriaxone resistant in our local area. The first child had gone to Mahabaleshwar and had some food over there during the vacation 10 days before the fever. This child was at home. The third child is from local, तुझ्या मनोहर तुझ्या बाजूचं कुठलं ते सगळे ग्लोबल सिटी मधला 1-year-old child. Sir, first time I saw the typhoid titer as 1 in 1 2560. One in 2560 titer, first time I've seen in my life. Mopkar was
We have
not.
also never seen. We have never seen so high titers.
Mopkar was not willing to give that report. I said, you give me the report. Sir, मी नाही देऊ शकत, खूप high आहे. I said, give me the report. The report are still with me. That child was admitted somewhere in Vasai Nala Sopara. That child had received 5 days of meropenem over there without any proof and came to us, started on ceftriaxone. 5 days of ceftriaxone, did not respond. This child did not have blood culture positive, but since it was fourfold rise in the titer, we labeled. So because the blood culture was negative and almost 2.5 weeks of fever was there, we took opinion and madam said that it is typhoid only. Again started on Septran and the child responded after 5 days. So typhoid has not remained a very simple disease. Typhoid is becoming a complicated disease. Beware of typhoid. It can land you in problem. Second thing I wanted to talk about is hepatitis A. Hepatitis A has become a very dangerous disease. Almost 10% of the 10% of the hepatitis A kids are going into hepatic cell failure. Lot of kids are requiring hepatic transplant. So kindly, please, I'm telling it 5 times that if you are admitting or if you are treating any child with hepatitis A whose SGOTPTs are more than 1,000, kindly do INR in all patients. That is the only test which is going to tell you the actual status of liver cell failure. If INR is 1.2 and above, kindly refer them to a higher center. Don't keep them. You will put yourself into trouble. You will put that patient into trouble because that child may go into liver cell failure and may require liver transplantation. So they are going to blame you for not sending the kid at right time. So any hepatitis, please do INR. Thank you so much.
मला काहीतरी सांगायचं आहे.
बोला सर.
एक म्हणजे टायफॉइड झाल्यानंतर पण पूर्वी टायफॉइड व्हॅक्सिन द्यायचे.
हो, यू शुड गिव्ह, यू मस्ट गिव्ह.
कारण टायफॉइड झाला तरी एवढी इम्युनिटी नाही की पुन्हा होणार नाही. हेच लॉजिक असेल किंवा पूर्वी 2दा टायफॉइड होत असेल, डबल टायफॉइड झाला सांगायचे का माहित नाही, व्हॉट एव्हर. सो हे तुम्ही भिंतीवर लिहून ठेवा की पूर्वी टायफॉइड झाल्यावर पण लस द्यायची.
अजून पण आम्ही देतो.
हो, तुम्ही छानच आहेत. माझा बरंच मान आहे, आमचा शैलेश पण मान. नंबर 1. नंबर 2, तुम्ही जो टीपीआर चार्ट करतात ना, त्याच्यावर वर आणि खाली तुम्ही टीपीआर साईन आणि सिम्पटम, तो जो चार्ट आहे ना, त्याला साईन आणि सिम्पटम, तुम्ही काय करता मला माहित नाही, साईन आणि सिम्पटम चार्ट करा. आपण जे टेम्परेचर पल्स बघतो ना, ते आर सायन्स. तुम्ही सिम्पटम्स लिहा, त्याच्यामध्ये तो लिहा, तो हसतो, खेळतो, खातो, तर ताप उतरत नाही, पण तो हसायला लागला, तो खेळायला लागला आणि तो खायला लागला, याचा अर्थ इज रिकव्हरिंग because fever immune response takes long time and it keeps us on in tension. So एंट्रिक fever मध्ये fever takes long time. So तुम्ही सिम्पटोमॅटॉलॉजीचा नक्की चार्ट करा टीपीआर चार्टवर. समजा त्याचे काय तक्रारी असतील ना, की याला कॉन्स्टिपेशन आहे किंवा लूज मोशन आहे किंवा व्हॉमिटिंग आहे, सर्दी, खोकला, समजा पहिल्या दिवशी त्याला 4+ आहे, 3+, 2+, 1+ झाला म्हणजे सिम्पटोमॅटॉलॉजी बरी झाली. सायन्स तुम्ही करता, टीपीआर करतात, पण तुम्ही मूडचं पण करा की हा हसतो, हा खेळतो आणि हा खातो, तर तुमची बीपी चाललीच आहे. हा स्वतःसाठी करा, स्वतःला वाचवायसाठी, आनंदासाठी. थँक्यू फॉर लिस्निंग.
असं नाही, मी जे म्हणालो ते अँटीबायोटिक रेझिस्टंट ऑन कल्चर रिपोर्ट बोललो मी. तुम्ही जे बोलले ना ते fever will take 10 days also. So after 3 or 4 days, the toxicity goes down. So we still continue with monotherapy. We don't add azithromycin. Lot of people add azithromycin, which we don't still use it. So खातो खेळतो बोलतोला आपण सिंगल ड्रगच आपण चालू ठेवू.
फाईन. एक 2 गोष्टी बोलणार. आता ललित जैन नाही आला ना?
ललित आला
का? असू दे. पण गेल्या 50 वर्षातली सगळ्यात चांगली मीटिंग ही झाली, कारण आम्ही आमच्या केसेस डिस्कस करतो. वी टॉक ऑफ रेअर थिंग्स विच वी रेअरली मीट. पण आज सगळं आपण आपल्या कामाचं बोलून राहिलो. तर आणि आता एक गोष्ट सांगतो, स्टीव्ह जॉब्स काय सांगतो, की सगळे मित्र एका 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 डब्यामध्ये ते दगड टाकायचा, त्याचा एक फ्रेंड, आणि ते हलवायचा. 24 तास हलवलं त्यांनी. तर सगळे दगड मऊ होऊन गेले आणि छान झाले. तर मित्र जेव्हा एकत्र डिस्कस करतात ना, तर ते भांडण करतात, पण सगळे हुशार आणि गोड छान होतात. तर हे आपण बिलकुल करायला पाहिजे. वी कॅन डिफर, वी कॅन डिस्कस, आपण केस पण ओढू पाहिजे तर एक दुसऱ्याचे, पण एंड रिझल्ट विल बी, वी ऑल विल बी बेटर प्लेस्ड दॅन व्हॉट. शैलेशला काही चान्स नाही. मला पण नाही, मी टक्कल केलं. मी शैलेशला बघून केस काढले बरं का. शैलेश मी किती फॉलो एवढं फॉलो करतो बघ, मी तुला ब्लाइंडली फॉलो करतो. तू चष्मा लावला, मी चष्मा लावला. तू केस काढला, मी केस काढले.
आता दाढी वाढवा.
हो, दाढी वाढवतो आणि ट्रेकिंगला येतो. येस येस.
पंढरपूरच्या यात्रेला पण जावं लागेल मग तुम्हाला.
मी जाऊन आलो. वारी करून आलो. पायी जाऊन आलो.
शैलेश,
त्या
शैलेश, तू बोलला ना विटामिन म्हणजे पीटी आयएनआर करायचं हेपॅटायटिस ए मध्ये. पण माझा एक्सपिरियन्स सांगतो की एका पिडियाट्रिशियननी काय केलं, पीटी आयएनआर केला, पीटी आयएनआर वाढलेला होता आणि त्यांनी मग आयएनआर वाढल्यामुळे विटामिन के दिलं, पण ही डिड नॉट डू द G6PD, आणि G6PD त्याचं पॉझिटिव्ह होतं. तो पेशंट वाडियाला गेला आणि त्याला हेमोलायसिस झालं होतं. म्हणून विटामिन आयएनआर
के,
जास्त असेल.
ऐकून घे. विटामिन के आणि G6PD इज व्हेरी फ्यू पीपल कॅन गेट हिमोलिसिस. सो आमच्याकडे G6PD डेफिशियन्सीला पण आम्ही विटामिन के दिलेला आहे. सो आय थिंक दॅट हिमोलिसिस माइट नॉट बी विटामिन के इंड्यूस, इट कॅन बी एनिथिंग एल्स. सो वी विल स्टील नॉट डू.
ओके ओके ओके, धन्यवाद.
Good discussion.
ललित,
Yeah, yeah, I'm
We can go to Lalit.
अरे
Yeah.
ललित है ना अपना
Now we welcome
हेपेटाइटिस
our
ललित विल टेल ना. ललित आया ना अभी, चाय
नहीं,
भैया.
मैं इधर ही था. You cannot see me properly. My camera is out. I was trying to connect from the phone, but
एक मिनिट, मला काहीतरी सांगायचं आहे,
yeah.
की वादे वादे जायतो तत्वबोधः. म्हणजे आपण एक दुसऱ्याचे पाय ओढू, पण त्यातून आपल्या सगळ्यांना छान शिकायला मिळेल. सो आय एम सो हॅपी. दिस इज द बेस्ट मीटिंग वी एव्हर हॅड इन लास्ट 50 years. सो थँक्यू अनुराधा, तुझ्यामुळे होते हे सगळं.
Thank you. Now I
अनुराधा मॅडम,
welcome.
मी नेक्स्ट टाइमला एक स्लाइड शेअर करेल की अटिपिकल
नक्की
कॉम्प्लिकेशन ऑफ टायफॉइड, इवन
नक्की.
कॉम्प्लिकेटेड. यस,
Sure, sir. Sure.
शुअर.
नक्की.
नक्की, जरूर. छान, युअर कॉन्ट्रीब्युशन इज गुड.
Now our next speaker is Dr. Lalit Verma. Sir is pediatric gastroenterologist from Bokart Hospital, Mira Road. We will be talking on approach to food allergy.
ललित, पहले हेपेटाइटिस का बात कर ले, बाद में एलर्जी का बात.
हा, एक मिनिट
Yes, yes.
त्याच्या आधी पहिले मला सांगायचं आहे काहीतरी. या संडेला आम्ही तो डॉक्टर्स डे करणार आहे VMA कडून. त्याला पार्ट स्पॉन्सरशिप आहे भारत बायोटेक कडून. त्यांनी ऑफर केले सम वॅक्सिन फॉर सम स्कूल्स ऍट ₹750 टायफॉइड वॅक्सिन. मला वाटतं सगळ्या आपल्या मेडिकोजनी आपल्या सगळ्या स्टाफला त्या रेटने देऊन घ्यायला पाहिजे. ₹750 रेटने, किंवा व्हॉट एव्हर बेस रेट यू गेट, सगळ्या स्टाफला टायफॉइड वॅक्सिन द्या. कारण ते आपल्या पेशंटला करतात ना, तर त्यांना टायफॉइड होणार बघा, आणि ते आपल्यालाच निस्तरायला लागेल. झालं. प्लीज कॅरी ऑन सर.
Yeah.
फूड अलर्जी.
Yeah. So first, I think what Dr. Bharat mentioned is very true. INR is one of it. And then first time, so at least we should send the complete LFT. Patient is affording, send all the LFTs, because sometimes SGOT, SGPD might come down, but the bilirubin might be trending up. Also, as he said, INR is very, very important to know the, like, what's going on with the liver. So at least INR bilirubin should be sent for all the patient with hepatitis. And recently, even in adults, we have transplanted patient, because might be because of different strains and all, but we'll have to see, because even post vaccination kits have come with hepa. Okay, so I don't have my camera on, sorry, but I was in the other meeting presenting infantile colic. अब उससे निकल के let's talk about food allergy. So the reason we chose this topic is there was a big discussion just last month about food allergies, and many a times we don't even know that food allergy does exist, but we keep ignoring it. Maybe it's within us, maybe with the family members, maybe the patients. I mean the kids and all. So let's see what we have in today. So there are a couple of cases I'm going to talk about. There is definition, classification, what's the prevalence, diagnosis, guidelines, and summary. Am I audible?
Yeah, yeah.
Yes,
Okay.
Lalit.
Yes, Lalit, you are audible.
Yeah, thank you. So, this is like the US data. So every 3 minutes, a food allergy reaction sends someone to the emergency. So you can see from this, like, there are 2 lakh emergency visits every year. And, nobody's going to just walk into the emergency without having urticaria or a severe reaction to it. Children with food allergies are 2 to 4 times more likely to have other related conditions such as asthma, atopic dermatitis, compared with children who do not have food allergies. So if somebody is having asthma and atopic dermatitis can
Just a
go
minute,
on.
Lalit.
Yeah.
Your slides are not moving and it's not full screen also.
Now?
No, not yet.
Oh.
Yeah, now it's moving,
Yeah.
but it's not full screen.
Yeah, because once I made it full screen, now?
It's not full screen.
No, it is full screen here.
Here
It
it
is.
is not.
That's okay, but you can carry on. At least it's
Carry
moving
on.
now.
It's okay.
It's okay,
So
but
this
it's
is
moving.
carry on. It is allergic to movement.
Now your voice is also gone.
Dr. Lalit, can you hear?
Lalit, we can't hear you.
Lalit, mail presentation to me. I'll share the slides.
Dr. Lalit? Yeah, he's trying to connect.
Lalit is not online.
Yeah, we can't hear him at all. Yeah.
He's joining back. Has anyone called him? Anuradha, have you tried calling him?
Yeah, he's
एकदा
trying to connect, madam.
Okay, okay.
Huh.
Thank you.
माझ्याकडे पण आता मागच्या आठवड्यात एक पेशंट होतं हेपॅटायटिसचा, तर त्याचे एचजीओटी एचजीपीटी 6000 होते.
Oh.
Sir, I've joined.
Manohar, patient survive झाला?
Lalit
हो
आ
मॅडम.
गया?
येस येस.
Lalit,
Yeah. One
okay,
second.
start please. Yeah, thank you.
ललित सर स्लाइड के सिवाय बोल दो यार.
Sorry, sir.
ललित सर आप बिना स्लाइड के बोल दीजिए ना कि आपका कनेक्शनच गेला का.
I'm in a hotel. I was presenting here. The connection is इनका Wi-Fi
नहीं आप
चला
सिर्फ
गया.
ऑडियो बोल
Connected
दो ना
with.
चलेगा. विल नॉट सी द स्लाइड्स. आपकी आवाज इंपॉर्टेंट है.
Am I audible अभी?
Anyway,
आवाज
Yes,
आ
yes,
रहा
you are audible.
Audible, sir.
Yes, Lalit, you are audible.
Let me just try एक बार खाली. I'll take the
करो
test.
करो करिए आप करिए तोपर्यंत अनुराधा तू मॉडरेटर आहे ना काहीतरी बोल टायफॉइड बद्दल मला काहीतरी सांगायचं बोलू का मी
प्रेझेंटेशन
सगळ्या कंपन्यांना आता कॉम्पिटिशन झाले ना दे आर ऑफरिंग वॅक्सिन ऑन लोअर रेट सो सगळे म्हणून आपल्या स्टाफला तरी त्याच्याकडनं लोअर रेटला घेऊन देऊन टाका बेस्ट लाईन रेटला घेऊन
That lower rate ones are expiry September this year. That is why.
असू दे ना आपण देऊन टाकू ना सगळ्यांना
हो हो.
आपल्या स्टाफला देऊन टाकू
पण जेवढी बी समजा गुड सजेशन सर
म्हणजे स्टाफला तर देऊन टाका ना आपला स्टाफ आजारी पडला की आपल्यालाच करायला लागेल त्याच्या पूर्ण घराचं करायला लागेल
येस
तर तुमच्याकडे कोणी ज्या कंपनीत जाईल त्याला म्हणा मला स्टाफसाठी बेसलाईन कॉस्ट करायला काय देतो फ्रीज दे म्हणा मला फ्रीज नको देऊ वॅक्सिन स्टाफसाठी फ्रीज खरंच सांगा आणि ना ऐका ना शैलेशने कोणाकडनं तरी फ्रीज करून घेतला तयार तर आपण सगळे 20 फ्रीज घेऊया तो नसेल करत तर मी नागपूरून करून दे शैलेश आहे का शैलेश गेला का शैलेश बिझी असेल वैभवी शैलेश आहे का वैभवी ऐकताय का
मी आहे
आहे का आहे हा बरं शैलेश सगळे मिळून आपण जेवढे 45 मेंबर आहेत ना त्यातले 5-10 लोकांनी घेतला तरी त्याला तुझा जोडी आर यू हॅपी विथ युअर फ्रीज
तर आतापर्यंत तरी काही प्रॉब्लेम आलेला नाहीये फ्रीजला
आणि त्याची कॉस्ट काय पडली तुला
तर आता माहिती नाही लेटेस्ट काय आहे ते.
तेव्हा तुला तू जेव्हा घेतली
तो शैलेश सर की ओपीडी कहाँ से निकालेंगे अंदर पेप्सी थम्स अप भी रखनी पड़ेगी
अरे मैं बेचता हूँ थम्सअप
सांग ना शैलेश
त्यावेळी काहीतरी 60-70 हजाराला होता आता माहिती
हा आता तो आपण आपल्यामध्ये आपण एक ग्रुपवर टाकूया कोणाकोणाला पाहिजे तर समजा 5-10 पीस झाले त्यामुळे 10 पीस साठी काय करेल तर बरं होईल
Okay, is it visible now?
Yes,
I think Lalit is ready.
Okay. Chalo, I'll not change anything, otherwise things will just go here and there. Okay, so sorry. So children with food allergies are 2 to 4 times more likely to have other related conditions, which is like atopic dermatitis, asthma, compared with the children who do not have food allergies. So this says it all. 25% of these reactions are viewed in those even with no known allergies. So as I said last time, Sonu Nigam never knew that he was eating prawns all his life, but he came up with a seafood reaction. Teenagers and young adults with food allergies are at the highest risk of fatal food-induced anaphylaxis. Can anyone tell me why? Fatal
सर
food.
बोलो हमको एमबीबीएस कोई नहीं आता था अभी आप कहाँ पूछ रहे हैं
Because
but why, this is a teenager.
Because they like to experiment with food and other things.
Exactly. So there is this peer pressure. Okay, this guy. So last time I did share some of the images where a kid who had dairy allergy, somebody threw cheese on him, and he had a severe reaction, went into anaphylaxis, and actually died. So there is a lot of this peer pressure, and everybody wants to say that I'm all right. There's nothing wrong with me, whether it's India or abroad, and that's the reason they will try and challenge themselves more with even with the something which they are allergic to, and that's the reason they will end up with fatal food-induced anaphylaxis. Now, going next, the slide is not okay. Can you see this slide?
Yes.
Prevalence.
Yes,
Okay.
Lalit.
So once I enlarge the screen, it's not showing. So I'll just keep it this way. So newborn 2.5% during the first year of life are diagnosed as allergic to cow's milk. Peak prevalence of any food allergy is roughly around 6 to 8% at the end of 1 year of age. Now in UK, the peanut allergy is high. It's around 1.8%. In US, it's around 1.4, and it's Australia about 3%, which has doubled in the last 10 years. If you look at the next sentence in US, prevalence has increased from 3.4 to 6.1. This is between the age group newborn to 17 years. Now, fish allergy seems to be more frequent in Asian population than in Western, and I would say yes, because a lot of patients who come, they were either they are eating fish or some kind of seafood. Among food allergic infants, approximately 80% will reach tolerance by fifth birthday, but 35% of these kids may end up in hypersensitivity to other food. So somebody is allergic to milk, will get rid of the milk allergy, but can have allergy from chickpeas or from lentil or some other form of food products. Am I clear there?
Yes.
Okay. Going forward, what are the allergic symptoms. So it's not just they get reaction on the skin and they have breathing difficulty, but if you look on the left side, there is trouble swallowing, shortness of breath, repetitive coughing, and voice change. If you look in the GI perspective, there will be severe nausea and vomiting, diarrhea, and abdominal cramping. So not all. So when you have a child presenting with nausea, vomiting after eating certain kind of food, maybe a seafood or peanut, then think about food allergy. Now, on the right side, one or more symptoms can occur within minutes. Up to 2 hours can be mild to severe. Now, there can be swelling, hives, eczema, itchy red rash. There can be a drop of blood pressure, loss of consciousness, and of course, death may occur in case of anaphylaxis. Now, what are the how does a child describe symptoms? So, an older child will be able to tell you some of this. He'll say the food is too spicy. जुबान में कुछ अटक गया है, there's something stuck in the throat, lips feel tight, mouth feels funny, there is a frog in my throat. This is more of the Western data. My tongue or mouth itches, my tongue is hot or burning, and it feels like there is a bump on the back of my tongue. So all these are subtle symptoms which the child is actually describing to the caregiver. So have always keep an eye on that. Now let's look at this one case. Sorry, the answer is there because I could not do that animation, but it's fine. So a 12-year-old girl with history of asthma, with 3 to 4 days history of increased work of breathing, cough and wheezing. Short-acting bronchodilator was used frequently without resolution. On day of presentation, she woke up with suffocation, lips turned blue, O2 saturation was 85. There's increase in RR, poor entry bilaterally, and there's wheezing in the upper zone. She was treated with salbutamol, atrotropium, steroids, IV, and MAC. Chest X-ray showed hyperinflation, and no focal findings were found. Now, on the right side, the past medical history-wise, she was following up with the pulmonologist with good adherence to medication. There's no exacerbation in last 6 months, but the caveat here is that there was wheezing, dyspnea, and pruritus with exposure to peanut, chickpeas, and lentil that she was exposed because she had a peanut butter just before this episode set in. So anybody who wants to describe this case?
Describe matlab?
What do you think? What is going on here? So the girl definitely has asthma, but she also has
Anaphylaxis.
or a food allergy causing anaphylactic like attack, right?
Yeah.
Acute
So both
exacerbation.
yeah, so both the condition can coexist, and I think it was mono, right? So it can a food allergy can exacerbate the symptoms of asthma, so vice versa. So we always say that certain things are there with eosinophilic esophagitis also. A kid with eosinophilic esophagitis can also have asthma in the childhood and can later develop eosinophilic esophagitis. That's in subsequent slides. Now case 2, this is very simple. Female infant 4-month-old recurrent loose stool for 2 months. Stools were non-mucoid, occasional bloody streaks. Infant formula was introduced at 2 months. Course of antibiotics and probiotic did not show any improvement. Initial diagnosis of lactose intolerance was made, and hence the formula was changed to soy. But no improvement was seen again. And then tentative diagnosis was of CMPA. So cow's milk protein allergy is a form of food allergy. So it is the first one which starts picking up by 2 weeks, and then it can become very aggressive by 3 to 6 months with blood in stool and so many other things that we have already discussed in the past. So again, cow's milk was excluded from the diet of the mother, and hydrolyzed formula was used, and the child was all better with the blood stick stools in next 2 weeks. So family history, there was a family history in mother with allergic rhinitis and asthma in one of the maternal uncle who was a mama. So all these allergies do coexist in the family as well.
Can I ask a question, Lalit?
Me
Yes,
too.
please.
Why this
Yeah.
patient didn't improve on soy formula when cow's milk was substituted?
So good question. Actually, 30% of the times, kid with cow's milk protein allergy can also have allergy to soy protein. So there is always an overlap of around 30%, and some kids will not do well even with soy-based formula.
Was this your patient, sir?
This was patient from Vasai only, I think.
Okay. So, would he? I'm happy you gave hydrolyzed food. Would he take just rice and dal? Would that be, if a patient doesn't afford hydrolyzed food, can we give him rice and dal? in such
Yes, yes.
patients?
So older kid, we always tell them to cut down. But sir, the problem here
4 months
is,
baby.
Yeah,
yeah,
4 months takes rice and dal very well.
5 months I do start. But the other thing is, sir, they will want to give some milk. So of course, if the child is breastfed, we tell them that it's okay for mother to not uh, herself drink dairy or consume dairy, continue with the breastfeed. So that is the first thing we do. But some of these kids actually come. So there was one kid I told, I must have mentioned sometimes back, 8 years back, maybe, came with dehydration. Dr. Barot is here. Dr. Barot.
Yes, yes.
So Dr. Barot ka one patient from Jodhpur was admitted in Jodhpur with dehydration, was treated with 7 days of antibiotic, came to Vidar again. I just saw him, I think, last month. Right, sir? The kid
Yeah,
had
yeah, yeah,
CMPA,
yeah.
and of course, the child was breastfeeding, but mother ka milk enough nahi tha. So that's the reason we told them ki if you want to continue milk, he was not doing good on so that's the reason we told them for hydrolyze. But Yoshi sir, we always start them on breastfeeding. We continue the breastfeed by stopping mother's dairy. If there is formula fed baby, then we first try soy. If soy doesn't work, then we go to hydrolyzed formula. Because some
Good.
of these kids will have faltering of weight and can even die with, shock.
Right.
Yeah, that's it.
Well taught.
Yeah. So adverse food reaction. So basically, there are two ways where a reaction can present. One is the immune reaction, which is immune mediated, uh, under which falls your food allergy and the food sensitivity. So basically, let me see my cursor. Yeah, it's moving. So one is IG mediated. The food sensitivity is non-IG mediated. IG is more to do with triggers of histamine and basophils. It has rapid onset. That's why you have swelling, hives, trouble breathing, and anaphylaxis. The food sensitivity, on the other hand, is non-IG, so it will be slow. It's by type 3 and 4 reactions. So it's cell-mediated and antibody. It takes its time, and sometimes there's a delayed onset of 72 hours. So we should always check the history whether a new food was consumed. And most of the time, the food sensitive will present with mostly diarrhea and vomiting, will not present with shock. Now, non-immune mediated is basically your food intolerance, which happens with carbohydrates. So we know about secondary lactose intolerance, which comes after. Do Indians have primary lactose intolerance? No, because it usually happens only in Scandinavian countries where they have lactase primary deficiency. Most of these lactose intolerance come after an episode of viral infection or bacterial infection. When you give them milk, they will have diarrhea. So transiently, we change their lactose, containing formula to a lactose-free formula, which is your soy-based formula. So one is lactose intolerance because of lack of enzyme called lactase. Second is pharmacological, which is your consumption of caffeine or histamine associated food, wine, chocolates, and all. So both these reactions are rapid in onset, mostly causing bloating and osmotic diarrhea in both the circumstances. Going on to the next one. Uh, so basically this is like how a child presents with the effect of food allergens as well as airborne allergen. So if you see the food allergy, of course, which is your purple, comes early, and by the time it's 5, they get better, right? The second is your asthma. Again, asthma peaks in your first 2 years, then again is at its peak at 6 to 7 years, and again during teenage years it gets better. But your eczema again is at its peak and then again gets better. What does not settle down is your rhinitis. So rhinitis actually starts peaking here, and this is the yellow line. If you can see, it's very kind of sluggish here, but this is your rhinitis line. And then anaphylaxis is always there. So anaphylaxis, this is the line, this is always there. It can present in the infancy, it can present in childhood, and it can also present in the adulthood. So as I said, one of my Bukhar's director's wife was having seafood at Mahesh lunch home in Juhu, ended up with bad anaphylaxis. Kokilabin was nearby, was taken there, was intubated and salvaged and saved.
And she never had allergy before.
No, so they are Goans actually, and she was eating fish all her life. And then both the kids I'm also treating. So now there is increased anxiety because even with certain kind of bloating and diarrhea, they get okay. Maybe it's food allergy. One of the girls' child has the allergy, but the boy does not.
Are they carrying adrenaline
Epipen?
everywhere?
Yeah, so what the arrangement that we have made now, it's pre-made, they stay in Santa Cruz. So I think they follow with Dr. Valvankar if I'm not wrong. So they get it done there.
Okay.
Lalit, usually with shellfish, na? Crab and prawns, food allergy, sea fish.
Huh? Sorry.
Lalit, it is usually with the shellfish, na?
Huh. So lobsters, shellfish, and crab, three main ones. River
Ah,
fish, I mean, I don't know. I'm not a fish eating person, but
ah.
usually when they ask me, I'm like, I think river fish is milder because when they say, I keep asking them. Also, there is increased, kind of incidence of pancreatic, I mean, GB calculi and even pancreatic duct calculi in the Palghar belt. And when I take the history, around 30 or 40 patients with seafood have calculi. This is like I've noticed in the last 10 years. It's just an observational thing, nothing else. So
ललित जी
in
एक
short,
वन
हाँ,
डाउट, थोड़ा पीछे का स्लाइड पे जाइए ना, योर ग्राफ साइड या. So what are these lines of, do they say incidence or whatever? What do the lines
so
show?
yeah, so this is the peak incident, this is the incidence, and this is the age. So
Is it in
basically,
one person or is it in population you are telling? Is it
no, no, this
population?
is population. This is population wise. This is population wise across the globe.
So you are trying to tell us that the incidence of asthma declines after the age of 7 years.
It stabilizes. See, this is the asthma line.
Right.
It does not go away, but
No,
your peak is here.
but it
Your
goes down
peak,
after 7 years, right?
yeah. So 8 years, 9 years, 10 years, and then it follows this. So we don't know beyond what happens in the adulthood, but
Okay.
the definitely it is lower, right?
Means if suppose this is 100, so if there are 100 people at 7 years, there will be 50 people having asthma at 13 years. Is it?
I would say so. Probably you guys see more asthmatics than I do.
Okay. Okay.
But this is what.
Let's talk about food allergy. At 2 years, suppose you see 100 patients, and later on
Huh.
you see less patients. Is it?
Yeah, yeah. So food allergies for sure. So food allergens, as we say, like dairy ke liye, when we say see, cow's milk, so we say by second year, almost 90% get better or get rid of the food. That's the reason we start introducing dairy in them. And just by third and fourth year, some babies will still continue with, cow's milk protein allergy reaction in the form of, loose stool or sometimes blood in stool. But by fifth year, definitely they all have got rid of it. So I must be seeing 100 plus patients, and nobody beyond 5 years has allergy to dairy anymore.
Okay. Okay. Good. Thank you.
Yeah. So sensitization to food allergens were thought to be like the start of allergic march. So now we have been worrying about allergic march. So basically, it's the food allergy where there is a then later increased incidence of atopic dermatitis and eczema, followed by increased episodes of asthma and rhinitis as the child grows into the childhood. So reducing sensitization to foods was therefore considered essential first step in the prevention of further allergic march. So if you are able to control the food allergy in the infancy, there are chances that there will be lesser incidence of asthma, rhinitis, eczema, and atopic dermatitis. Now, here there are some of the risk factors for development of food allergies. Some are strong, limited, and lacking evidence. So, the strong evidence is suggestive that sex, boys and girls both have equal, percentage of risk of food allergies. Race-wise, if you see Hispanics, Black community, and Asian population have higher incidence compared to the white ones. Genetic, definitely, familial association is related with specific genes and HLA. And then, of course, delayed peanut introduction on high risk patients is a no-no. So initially, when we started, when I started residency in GI, they said the subspecialization. They said, "Oh, let's introduce allergic component late." So we started giving nuts and all after 3 years. But then the other study came where they said it is better to introduce them at the right time rather than delaying it. So again, we have gone back and saying, okay, even if there is an increase in the family, do not delay it in that particular child. Give whatever component is there at the right time. So somebody who, if the family says that it is allergic to gluten or has celiac disease, but no, if the child is born, then start giving them gluten at 6 months of age only, and only then we'll know whether the child certainly has gluten allergy or not. There are limited evidence to certain of these things, which are vitamin D, reduced ingestion of omega 3 by mother, route of delivery, which is C section, types of infant formula used, delayed in introduction of food known to be allergic. So as I'm saying that, there was this thing in the West that do not start eggs, milk, and wheat early, delayed, but that was causing more problem. And then increase in hygiene. So decrease exposure to microbes is one of the important thing. So nowadays we say not blood bath, but what do you call the matti wala bath. So basically, do not try to be over hygienic. So this is one of the study which came again from Italy. The third one is lacking evidence. So it's not related with pertussis vaccine anymore. It's not related with folate deficiency. Antioxidants do not have any role here, and childhood obesity does not has a role here. Now, the most common food, eight of them, so we call it like the super eight. So if you see, there are percentages given here. Milk is the max. It's at nuts are the max 25, followed by milk at 21. Then are your eggs, shellfish. I think one of the doctors was asking wheat, and then of course tree nuts, soy, and milk. So these eight are very important. So when we have a, a child with multiple food allergies that we don't know, then we first try and stop four, and then we add two more, and then we again stop more.
सर
So
चाय
this is
पीने से होता है क्या?
चाय पीने से नहीं होता है, पी लो. So I'll just skip this because there are many more slides. Actually, slides we move near easily. So in an anaphylaxis, you'll see systemic reaction. So it does not involve one system, but many organ system, multiple symptoms. It is acute in onset. Of course, it is IgE mediated, and it can vary from mild to fatal. So we do not have much time. It's better to move them to a center which can offer them help, but better nearby. So, acha, this, let me just try this. Can you see this? Anaphylaxis
Yes.
are.
Yes.
Yeah. So an epi auto-injector is used to treat anaphylaxis. Mostly it is EpiPen, but it's very expensive. So we've been using our own. But as this says, like, you can see this one also, right, Dr. Anjali? We can either
Yeah,
save
yeah,
the
yeah.
next
We can
child.
see that. Yes,
Okay,
Lalit.
we can either save the next child with stock epinephrine. It can be EpiPen, it can be premixed at our center or which we had. So this is very important when you have a child. It's very important that you give them one in the back for the school, keep one with the school nurse, keep one in the back. So in case they are traveling, there are certain bracelets available. We'll talk about it later. Yeah. So this we already know, so I'm not going to talk much. CMP I've discussed many a times. So basically, it can be IG and non-IG, but the symptoms here are diarrhea, vomiting, blood in stool, and failure to thrive. 15% of these kids can also have increase in colic pain and GERD. Uh, Atopic dermatitis and food allergy, definitely. 40 to 50% of patients with severe atopic dermatitis have some or the other form of food allergies as major trigger. Food allergy in 20 to 25% with less severe AD is known. In this case, egg allergy is the most common one, followed by milk, peanuts, soy, wheat, and fish. So this six food accounts to more than 90% of food sensitivities in your patient with atopic dermatitis, and 36% react to one food, 26 to 2, 18 to 3, and 10 to 4, so on. So basically, when you have a kid with atopic dermatitis and the compliance is good but not getting better, then think about food allergies and at least try and cut down on this six of them. So start with two, add two more if not improving, and add two more. So basically, if a young child might not be consuming fish, so we can take that out. Peanut is out definitely. So start probably with the milk if your child is not doing well with all the precautions. Now there's something called eosinophilic
Your
esophagitis.
slides are not moving. Lalit, your slides
Again,
are not moving. Yeah.
Acha. Okay.
Yeah.
Yeah, that is what there's some issue here, maybe net or my. Okay. So EOE is something, which is called disease of the West, but I don't know why. While training in Canada, I had a lot of patients of Indian origin, but I don't see them much of here. I've not seen a single child with EOE. So EOE is well-known member of family of allergic enteropathy, which is characterized by GI tract infiltration with eosinophils. So a lot of eosinophils just get into the esophagus. It can even cause gastroenteritis and can cause colitis in the form of blood in stool or diarrhea. So most estimates in the US range from 40 to 90 cases per 1 lakh people. So that's quite a good number. Prevalence of EOE in children can present with dysphagia and food impaction is very high. So a lot of this pediatric population will come with something stuck in the mouth, while eating. It can be a bread, mostly dry things, bread, chapati. If they are meat eating, then it can be a steak. EOE occurs approximately in 4% of children with celiac disease, and more than 50% of the patient with EOE have personal history of allergy or eczema or asthma or rhinitis or multiple food sensitivity. So all these allergic conditions go hand in hand. They can have one or the other form overlapping. So this EOE symptoms can include reflux, nausea, food aversion or refusal, food impaction, growth failure, and sometimes they complain of chest pain. And the line of treatment here is giving them PPI for a longer duration. So do I go over this? I'll just tell you exactly how it happens. So basically, when you do an endoscopy, you'll see rings in the esophagus. There are strictures or narrowing also there, and more when you do a biopsy, there will be increase in the eosinophils when you do a biopsy sample here, and it can also lead to reflux because of dysmotility, and it can cause decreased epithelial integrity, allowing eosinophilia to happen. So treatment wise, what do we do? Basically, we start them on PPI, proton pump inhibitor, for 8 weeks. Um, Long-standing untreated EOE often leads to esophageal strictures, so we'll have to like dilate it if required. Uh, but most of the times with the 8 food elimination that I told you, they do better. So we try to take away 6 food elimination first and then add 2 more if required. So basically, the way to do is adding a PPI, then having them to avoid the 8 important food, which we discussed earlier. And then an infant or child with EOE refers to us only. Okay, that's fine. Any doubts there? EOE?
No, no.
Okay. So coming to non-IG mediated reactions, it presents more in a subacute or chronic fashion, typically isolated to GI tract and or skin. So basically, it's skin and GI only. So one is very important. I had a very sick child with F5s. So basically, they introduced rice, and the child just got F5s at 5 months of age. I started thinking कि milk hai, but nahi, it was rice water, and the kid had something called food protein induced enterocolitis syndrome, where you can have vomiting and diarrhea to that level that they will go into dehydration and will need admission. Then there is something called food protein induced enteropathy, which is involving your small bowel. And the third one is food protein induced proctitis, basically involving your large gut and large bowel, and proctocolitis, where they'll have blood in stool. Then something which is very concerning is the food-induced pulmonary hemosiderosis, which is a Highness syndrome. Some of this kid get into interstitial lung disease and do not do well when they get into in a teenage age group. Uh, Celiac disease, although is not considered food allergy because although it is caused by non-IG mediated reaction, but it is a reaction to a food protein called gluten. But somehow we have not included it here. Now, F5's most common cause, basically it's non-IG mediated, and the most common cause is cow's milk or soy protein. Although other foods, like in this case of mine, was rice, oats, shellfish, can be a trigger. Postulated to due to ingestion of food allergens can cause local inflammation mediated by T cells, and then there can be a fluid shift causing more of diarrheal symptoms. Affected children are often misdiagnosed as having acute viral GI illness or sepsis, and hence delaying in the diagnosis. So most of these patients, when they come to us, will always think about infection because in a tropical country, that's the first thought. But if they're not responding to routine therapies, think about F5s. It primarily affects infants. So think about it, as soon as you have introduced rice or cereals or dal, think about F5s if the child presents with severe vomiting and diarrhea. Symptom of classic F5s usually begins within first to 1 to 4 weeks following introduction of cow's milk or soy milk or any other food product. Solid food F5s tends to present when these foods are first introduced between 5 and 7 months. So always think about those. And systemic food specific IG antibodies are not detected when a patient has F5s because it is non-IG mediated. Symptoms of F5s, they can have a very sick child with lethargy and pallor. Usually they present with watery or mucoid stool. Grossly diarrheal stool is possible, although rare. Vomiting is intermittent. In a chronic setting, can be severe and can lead to dehydration, as I said. Patient may also have malabsorption. They can have failure to thrive. So if you have introduced something in form of solid and you come across with a child who has started losing weight, think about F5s. The diagnosis is simple. It can be a lab-based diagnosis where you see low albumin, anemia, and leukocytosis. They can sometimes present with hypotension, lethargy, and shock. So we have to do the needful. Symptoms of FPI usually resolve with elimination of the causative food. So it can be several weeks to months apart. I mean, it will take. And if the causative food is later reintroduced, there is characteristic delay in the onset of 2 to 4 hours. So although we say, okay, the symptoms have gone away when you reintroduce, some of these kids can again present with the same FPIs, but just that it will not be like, immediately. It will take 2 to 4 hours to react. Any doubts there? Okay. So
No, sir.
diagnosis is based upon the presence of clinical features and by improvement seen with the withdrawal of the causing agent, which is your protein. So oral food challenge is sometimes performed to confirm the diagnosis, but if you have a child with FPIs, it becomes very risky. So let's not try that. Just take the allergen away for a few months and we'll see the healing part. So FPIs in older children presents with milder symptoms. They can also have nausea, vomiting, and cramping. And FPIs is uncommon in exclusively breastfed babies. So other non-Ig mediated disorders are protein-induced proctocolitis and proctitis, where they have mucus and blooded stool. And the other one is GE reflux, which we see routinely in your cow's milk protein allergy cases, as well as other allergens also. I'm just trying to go fast so that we can cover the rest of the slides. So non-Ig mediated disorders also include your infantile colic. That was my talk before. Cause of constipation in infants and children who do not routinely do well with your routine therapy, so they have refractory chronic constipation. Think about Ig mediated disorder. Highness, we know, is because of food protein induced pulmonary hemosiderosis and primary to cow's milk. So some of these babies will do well when you take away the protein or the cow's milk. Now, what is food intolerance, which is your abnormal physiological response to eating, non-allergic food hypersensitivity, as we call it. Food intolerance usually affects your skin, respiratory, and GI tract, usually presents in the form of nausea, diarrhea, and vomiting. It is not life-threatening. Symptoms are often confused with food allergies. Intolerance is more common than food allergies, we know that. It can happen with histamine toxicity when you eat cheese, wine, and fish. It can be because of lactose when you have deficiency of that enzyme called lactase, which we Indians have after age of 35. When you have MSG containing food, you can have food intolerance, sometimes with gluten, and intolerance with small amount does not usually happen. So an adult who has bloating with milk of say 100 ml, if that person cuts down the milk to 50 ml, probably will have lesser symptom or probably will have do not have symptoms. So it is amount dependent also. So how are food allergies diagnosed? So the first important prospect of this is knowing the detailed history. So suspect the food, timing, and specific symptoms which is causing the allergy. Think about SPT when the child is 1 year plus, because less than 1 year it will not give you a proper kind of erythema or nodules which happens in the SPT. So basically, some of the immunologists, they do it in Bombay also. Blood test in the form of IG can be sent. We also have RAS test, which is IG based test. Although there are a lot of false positive RAS also. Sometimes even your skin prick can give you a false positive picture. Must be carefully interpreted in the context of the clinical picture. So, for example, somebody is not eating fish, and when do your skin prick test and you have that allergen of the fish and reacts to it, that means that is false positive because the child is not fish eating bachu. So that way we interpret. So again, food allergies are also diagnosed in the form of oral food challenge that we routinely do in cow's milk protein allergy. Most of this reproducibility of reaction can happen. So somebody who's cow's milk protein allergy, if you give small amount of milk also, will again react in the form of erythema, diarrhea, and so on. If you're considering to send anything, then do a lab test which send hemoglobin, albumin, which will be low, and the white count will be usually high with left shift and eosinophilia. Stool studies will, of course, tell you about ocal blood and high eosinophil count, and reducing substance will be positive, but they're not very informative. How do you manage a child with allergy? Because this is really concerning. So there has to be a partnership between the school administration, class teachers, and others. They have to communicate with each other. So then is your family, parents, and the caregivers here. And then with us, the licensed healthcare provider, because then we have to give them a note that the child is allergic to, say, a particular antibiotic, and this is the course of action you should follow, or give us a call, or reach to this emergency if our number is not reachable. So basically, there is communication and education in the entire all of us treating or taking care of this child. Now, this is very important because there's something called cross contact and cross contamination. So basically, your cross contact is your allergen accidentally transferred from a food containing an allergen to a food or surface that does not contain that allergen. Cooking does not reduce or eliminate this allergen. So basically, uh, that allergen is transferred from one place to another. Cross contamination is with the help of microorganism from different sources contaminated food during preparation and storage. So cooking does reduce or eliminates the microorganism. Basically, so when you take this example of gluten allergy, we always say that do not use the same chakla belan that you're using to make the wheat based chapati. So that is cross contamination. So when you do proper cooking and cleaning, it goes away. uh, when you consume it, when somebody has cow's milk protein allergy, even when you cook enough, it does not go away, although when you give them paneer they can do better. Am I clear there?
Yes. So if a
Okay.
person is allergic to milk, can they have dahi?
So a good question. So this is we say that the first thing to start is ghee or dahi,
Okay.
because again when you boil it and then you kind of refrigerate it, the proteins are broken down into amino acid and then into deltons, and the allergy component goes away.
Okay.
But then it requires really high flame cooking and then keep refrigerating it so that it is broken down into delta. So
Okay.
this is a real case. Cross contact can be deadly. So Sabrina Shannon, this was a case from US. Teen had a fatal anaphylactic reaction during her first year of high school in 2003. So basically, reaction triggered by dairy protein, likely due to cross contamination from tongs, जिससे हम उठाते वो, used for pudding, which is your potato topped with curd and tomato base, after ordering French fries from school cafeteria. So this girl was allergic to dairy, and then although she was not having the same thing, she was only trying to order a French fry, but the tongs जिससे पकड़ते हैं हम वो जो use किया was used to lift this poutine up, which had potatoes with cheese in it, and the girl had a severe anaphylaxis reaction and did not survive. So it can be as bad. Food allergy action plan. So this is again important. So it's recommended for each child with known food allergy. So abroad, so they have this bracelet where we like they have the allergen mention on it, because if they go out on the street, anybody who's a caregiver or people walking on the streets will know. So basically, it outlines the care in the emergency. So severe symptoms and mild symptoms, what has to be done, and then basically is the child allergic to certain kind of food, and where does the reaction happen, whether it's gut or so on. So basically this is severe symptoms and milder symptoms here. So basically it has everything mentioned here. And we usually give them a formal plan written for the school, like in the case of mild reaction what to do, and when to give that epipen injection, and when to take help, and when to refer them immediately to the emergency which is nearby. So all these things have to be sorted out when you're dealing with food allergy, especially a child. So what to do if a child has reaction? So of course, take medication, seek medical help, keep injectable epinephrine ready, and wear a medic alert bracelet, which is I was talking about. So I think with the help of IAP, we should start doing this. Uh, of having allergic bracelet where it mentions the allergy once we know what the allergen is. Tips to prevent allergy: do not consume, of course, allergic food. Read the ingredients list. If traveling, bring your special food. When eating out, always ask about the food. So say for example gluten, so at least there are gluten free based restaurants, at least in Mumbai some of them are there, of course in West here a lot of them. There is always an allergen mentioned in any food packet, so always look into it. Have a plan in case of allergic response. Wash hands with soap and surface clean properly in case of peanut allergies. So again, most of our food products also have this label, but it may or may not contain. So the problem here is not safe for people with known food allergies. So when it says may contain statement, that means it becomes risky. Somebody is allergic to say soy. So if it says can contain soy, so just it's better to just avoid it. And when it says made on an equipment that also makes, that again, like, does not clear them properly whether it is made in a facility which also make baked food product when somebody has allergy to eggs, or wheat. So these are very kind of dicey areas where you have to gray areas where you have to keep a check. If it is says may contain or the equipment is made here, it's better to avoid. Children and allergies. So for babies, discuss formula options with the doctor. Don't introduce solids too early. Wait for about 6 months. Wait on the food items. So basically, your cow's milk definitely is by age 1. Eggs, we have been saying between age 1 and 2. And then peanuts, nut, and fish by age 3 or after. This is by American Academy of Pediatrics, but they have again revised it. So America and Europe go against each other. So some of the times the European will say ki, acha, eggs and peanuts and everything else is allowed after first year. And I think most of our Indian population also, when I talk to them, they've already introduced nuts and fish, and which I feel personally is okay. So evaluation of suspected food. 1 second. So just let me know. Can you see this now? Enlarged one, can you see?
Yes, yes.
Okay, okay. So symptoms suggestive of IgE mediated food allergy. Basically, a skin prick or a rash test will be a positive reported anaphylaxis reaction to the food that commonly produces anaphylaxis. So food avoidance and anaphylaxis treatment in the form of epinephrine, medical identification and bracelet is good. If there is no anaphylaxis or it is just suspected that this food might be a common cause of food allergy, then further evaluation with blinded and unblinded food challenge can be done if your skin prick is again positive. So, for example, if somebody says ki chickpeas ya chane ki dal se that person is positive on the skin prick, but mother has been giving or father has been giving something like gatia or besan ka laddu with no reaction, that means your skin prick is false positive. Then in that case, we can continue. So basically, it's kind of observation by the parents, and then also depending on your skin prick or RAS. Now, RAS, I don't trust because most of the time it is false positive only. If you really have to do it, it's better to do a skin prick by somebody who has been doing it routinely or she has been doing routinely. So if it is negative, allow that particular food in the diet. But if strong history of anaphylaxis reaction is there, then it's better to avoid and reintroduce under supervision. So as I said, if the person is not allergic to say crab, and there is a very strong history like that known director's wife, where there is a very strong history of crab in the family with anaphylaxis, is better to avoid crab even in the child and reintroduce it later under observation only. The use of antihistamine is not recommended as first line for severe allergic reaction or anaphylaxis. Although antihistamine medication may be beneficial to control milder symptoms such as rashes, pruritus, again, which are very common with milder food forms. So recently, what I've noticed is, reaction to avocado and to your what do you call uh, imported fruits in the form of what is that dragon fruit, kiwi. Have you come across any one of you?
No, I've never come across.
No, no,
Okay.
no. They're
So
not.
just try and think, if a person comes with dragon fruit or kiwi, I don't know, it's something to do with the preservative or because they're mostly imported. So I will have to keep an eye whether it's because of that. Now, new advances in the prevention of food allergy by early intake of food in infants. So this was this study done. Early food intake, I'll just try to take this away. So early food intake on the prevention of food allergy in infants, on the prevention of food allergy, they have achieved exciting results which have changed the prevalence, relevant content of the infant food guidelines. So this paper was it. Let me see if I 1 second. Again, it is hanging. So I'll just kind of tell you what exactly. So they felt that initially the thing was to introduce the allergic food food later after 1 year, but lately what the studies have showed that introducing them at the right time. So suppose gluten you introduce between 5 and 6 months, it's okay. Nuts can be introduced after 1 year. So basically there have been exciting. So instead of delaying the allergic food components for later in the life, it's better to introduce them at the right time or sometimes even early to prevent that allergic march. So this is how we, once we take care of the food allergy, it can also avoid the eczema or the rhinitis in the future if it has to develop in that particular individual. Primary prevention of atopy by food allergen avoidance. Anyways, that slide is gone. I don't know, something is wrong here. So basically this talks about cow's milk, hens, egg, peanut and seafood. So cow's milk reaction usually starts early in infancy and gets better by 2 years and then almost completely resolves by 3 years. Egg, if you see, peaks by the first year, peaks at around 3 years, and then again gets better. But if you see the peanut, fish, and seafood, of course, we do not give them an infancy. It starts peaking somewhere here after first year of life and then peaks later. So this is concerning because your peanut, fish, and seafood allergy can peak when the child is at the school going age, and that's where the concerns are. And then again, it can remain the same even in the adulthoods. There can be a spell where the an adult or teenager is doing fine, but it can still exist. So sensitization to food and sensitization to allergens. So there have been prenatal sensitization which people used to do. So mothers were offered the allergic component and then they were washed. Natal sensitization is what we spoke about now, that it can be done by giving small amounts of those allergic containing diet in the food. So suppose there is a strong family history of uh, peanut allergy in the family, but then you do introduce them slightly before. So instead of 1 year, you can start giving them or sensitizing them at 6 months of age, and they say that that might sensitize. I mean, kind of that can stop the allergic march. Some slides here are not moving. Can I just stop the sharing and then I just
Yes, yes, Lalit.
yeah, because it's kind of hanging here. Okay, so basically, sensitization to the food is in the form of eating, touching, and smelling. Um, I had one patient with celiac disease, but was never diagnosed as celiac disease. There was significant hypoalbuminemia causing what do you call ileus, was actually kept in the ICU for ileus, and then of course they came to Mumbai, and I was like, something doesn't feel right, and then the child was diagnosed as celiac disease. That is one thing, but then the child again continued to have symptoms even after stopping the gluten. Then when we figured out that there was a chakki just behind their house, I think they are from Jalna or some place inside Maharashtra, and then there was this dust coming in the form of environmental dust. So that was chakki ka atta coming, and the child still had symptoms, so they had to close that window and the child got better. So this is, I came across one of this very interesting case here. Then the last few slides. So immunotherapies also have been used. So there is something called monoclonal antibodies, which is your anti-Ig in the form of omalizumab and dupilumab. So in US they do it. So if somebody is like selfish allergen, then they try to give omalizumab in those patients starting at 6 years of age, sensitize them, kind of desensitize them, but it is very costly and it has a cost constraint. Then there's something called mutated allergen protein immunotherapy, which can be tried. Peptide immunotherapy is what we use in the form of hydrolyzed formula. Immunostimulatory sequencing very rarely, and then the role of probiotic is questionable. But I always think that when somebody has allergy, there is dysbiosis because the lining is inflamed. So giving a week's course of probiotic definitely at least will take care of not the allergen, but if the child has diarrhea, it can take care of that. Coming to the last slide, summary. So recent epidemiological evidence suggests food allergies prevalence continues to increase in the worldwide. Maybe that we are seeing more and picking up more cases, I would say that. Determining food allergy mechanism is essential to establish diagnosis and management to be used. Patient history exam are the most important approaches during food allergy evaluation. IM epinephrine or IV epinephrine is the IM epinephrine is the first line treatment for anaphylaxis and severe IG mediated allergic reaction. IG mediated food allergies are more likely to resolve during childhood, which are your cow's milk, egg, wheat, and soy. And others such as peanut and tree nuts usually persist in the childhood. So again, adding here to peanut and tree nut are your fish and shellfish. And then based on strong evidence and consensus guidelines to provide peanut allergy prevention, early introduction of peanuts at 4 to 6 months of age is recommended. in children with severe eczema and allergy to eggs as well. Based on the consensus, an allergist referral is necessary to establish a definitive diagnosis and management of food allergies. So I usually send them to confirm the same with the help of skin prick. I send them to Dr. Farke. So he must have done 100, somewhere around 150 of my patients, which I think had uh, have food allergies and have elevated levels of IgE. And then you just have to get that skin prick done to just confirm it. So that was all about today. Sorry for the slides. There have been some issues here. Not been able to say so. Any questions?
No, great presentation, Lalit.
Thank you, ma'am.
You made us
I
aware
think
of all these allergies.
I think nowadays mothers are not giving breastfeeding to the babies. That must be the cause, one
Of
of the
so
cause.
much allergy, yeah. Yes,
of
yes.
food
Introduction
allergy.
of bottle and top milk and not
Lalit,
giving breast milk.
Lalit,
Yeah.
yesterday I saw one patient, one and a
Hmm.
half year old child, who
Yeah.
came with tightness and red rash while eating. He was
Okay.
eating green lantern and chana,
Yeah.
some liquid, usad.
Hmm.
And he was, when he came over here, he was absolutely fine except for some rash here and there. So we
Hmm.
said that you wait over here and under observation, and child was hungry, it was dinner time. So he ate the same thing and he went into anaphylactic shock in the ward, in the hospital.
Oh.
He was pulseless, he became cyanosed, he almost choked himself, breathless, and we had to give him adrenaline, hydrocort, IV fluid resuscitation, oxygen, and he fortunately recovered. But he's been eating regularly tur dal and moong dal, but the whole green lentil moong and chana. And mother retrospectively today told me that 1 month back also he had similar episode. So how to put forward that the outer covering which is allergic, or the it was something different only, or it may not be an anaphylaxis to moog and chana.
So good, good. I mean, was well managed. I'm happy. But I think here, so of course, chana dal, I've come across patients who have allergic to chana dal. The whole moong, cover wala moong bole na.
Yeah, yeah.
Usually, I'm not seen to it, but see, there can be reaction to even bell pepper, chili, mirchi, haldi, किसी से भी आ सकता है. Certainly, the first form was milder, but then again, it is, as I said, the 25% of the times we know that it can be like happen for the first time. But in this case, the child had some symptoms, which was a milder one, luckily. Second time again got grave symptoms. So definitely, sir, I would send an IgE, send for a skin prick, mention all the food items so that the allergist can prepare the allergen for the skin prick test, and then see what the skin prick test shows.
Okay. Thank you.
Because SPTs have been very helpful and Suyoga is doing a wonderful job. So he gives a kind of description ki Lalit this aisa, and then induration was there. It's just like a PPD placement, Monto placement. वैसे ही वो आ जाता है. Skin pick is really good.
Can you send me the number
Yes.
of that? Yeah,
Yeah, I'll share that.
yeah, please.
Can,
Thank you so
can
much.
you please put it on the group so that all of us get it?
Yeah, I'll put, definitely will put. And then also we can come up with our analysis. Like, of course, you've seen so many patients, and then, there are subtle symptoms, as sir mentioned, in that patient, where there's only some kind of, tingling, or the child felt something is not good. It can present with lip swelling, but then you better to observe them for 24 hours, because the anaphylaxis can be delayed after 2 hours. So it's better to keep them for 24 hours if they're coming. So I saw one of Samir's patient, or maybe I saw in his clinic. So I had similar things. So that kiwi patient, so I've seen 3 patients with kiwi where they, even if they touch, there are some kind of reaction. So other patient was very bad. I told him to get admitted, but so I had to mention Dama, Lama, whatever. But then, yeah, had severe reactions. There was lip swelling. There's significant urticaria throughout. So at least even if they're not willing, we should tell them to have EpiPen ready, and then get admitted is the best thing.
Lalit, I wanted to ask you that the skin test that they do for allergens
Hmm.
is the same as the skin test they do for asthma?
Yeah. So they have food allergens, then they have environmental allergens, in the form of I think dust mite, dog dander, some pigeon droplet का कुछ तो रहता है, cat dander and roaches का something is there. So it is all dependent. Most of them will have 40 allergens, which involve mostly food, but also your environmental and asthma allergens. And then some of them, I think Suhog has a good collection of around 80 allergens.
And that's all given into the skin.
Yeah, all on the skin. So mostly back, um, older
Yes.
kids on the forearm, like the front aspect of the bilateral
Volar
arm.
aspect. Yeah.
Yeah, and then the younger kids on the back because it doesn't hurt much, but it's like just putting a pen tip on the skin. So थोड़ा सा तो hurt होता है.
And another thing I wanted to mention that EpiPen is not available in India. So we recommend carrying adrenaline injection in small boxes and along with a 2 cc or a tuberculin syringe. Any plastic case can do for that. And the dose is 1 tuberculin unit per kg of the child up till 12 years. And maximum dose is zero point 0.3 ml, that is 30 TU, and
Correct.
adults the dose is half cc or zero point 0.5 ml. So and or any child about 12 years, and that
That is
dose
the
can be written on the box and given to the patient, and the mother can be educated how to give it. Like
that is
I think Shailesh's patient will be at risk next time. You won't reach the hospital also, so
Yes.
you have
exactly.
to give the
Yes,
injection.
sir.
And also at the school, like the school
Yes,
is
and
a
also
place
in the
where
school.
school sometimes even the nursing they don't understand school के nurses and they just feel that somebody wants to go home. So I think we'll have to like vouch for it and tell them that these allergens are
Yeah.
really life threatening. And then as you rightly said, what is the shelf life? How like how
So
frequently do you ask?
initially, adrenaline used to come with very short shelf life, but now it comes with at least 1 year expiry, and we can write on the outside expiry date on the outside of the plastic box so that the patient and the relatives are aware. Or every Jan and July they have to check, so that once in 6 months they check the date.
No, they're actually good. And I think 6 months, they should always keep checking and that
Yeah,
is
it's
good.
life threatening.
Yeah. And even for Dr. Barud's patient, I think we'll have to mention the food allergens and mention in the chart and give it to the school people also because
Yeah.
there can be cross contamination. The other kids can have it and the child can end up having that.
And for how long will this patient now be off moong dal or whatever?
So at least when we say then with bad anaphylaxis, so it ideally to be like do
Lifetime.
forever, yeah, lifetime.
Okay.
And then milder reactions we say wait for 6 months to 1 year and then again reintroduce in a controlled setting and then restart. So many of them have milder form of reaction. But when they come to us, that urticaria has almost settled. And then even with significant urticaria is something which I say is not a mild but moderate reaction, I would say. Just that the next level is
Want to be severe.
anaphylaxis. Yeah.
Dangerous, sir.
So it's very important to get them evaluated for the allergens that they have and take it from there.
Okay. And so a lot of adult patients also say I'm lactose intolerant. I'm lactose intolerant, and they have been, not even some children they don't give milk products for like lifetime, and
Yeah.
so I want to know, but they will happily eat ice cream and things like that. So I want to know about milk intolerance.
So that's another important and good aspect that you asked because I feel that although there is cow's milk protein allergy, but not every child is, kind of sensitive or allergic to dairy. So the worst thing that we can do for any of the vegetarian population is take their dairy away and take your vitamin B12 away from them.
Yeah.
So as you said, at least even if you are thinking okay it is cow's milk protein allergy, after 1 year so we all start we I usually start them with ghee and then baked gulab jamun and whatever they can and slowly take them to milk. So I
Okay.
usually put them back on milk when I see कि किसी ने बंद किया है. That's my story. And
क्या बंद किया है?
मिल्क अगर बंद किया है तो आई एम लाइक ओके कितने दिन से बंद है, अच्छा छोटा थोड़ा सा मिल्क देके देखो उधर reaction comes in the form of diarrhea again, then you stop. But yeah, severe
Okay.
form of anaphylaxis though is usually dealt in the infancy. So that cow's milk protein allergy wala part is done. But at
Okay.
least some form of dairy and vegetarian population in the form of paneer, curd is important. And I
Okay.
always emphasize that some form is important.
Okay. So if they don't take milk, at least paneer and curd can be given.
Yes, yes.
Okay. Thank you.
तुम एंटी वेगन हो क्या?
हाँ,
आप एंटी वेगन हो क्या?
मैं एंटी वेगन तो नहीं, but somebody is having. I consume paneer cheese. I don't
नाही
personally drink milk,
नाही,
but I am
नाही,
not vegan.
मी मजा कर रहा हूँ.
हा.
अच्छा, सगळ्यांसाठी झाला का हे आपली मीटिंग अकॅडमिक झालं का?
हो
हे
हो.
कुठे गेले? अनुराधा.
आहे सर.
आता व्हाईस प्रेसिडेंट कोण आहे? प्रेसिडेंट नाही येत आयआयपीचा आपल्या?
डॉक्टर
आपल्याला व्हाईस
बारोट सर.
प्रेसिडेंट हा
डॉक्टर
बारोट
बारोट
सर आहेत
Doctor
ना?
Shailesh
गुड
Baruch.
गुड. ऐका ना, मी आय एम कन्वर्टिंग दिस इनटू जनरल मीटिंग ऑफ आवर ब्रांच and I am proposing that IIP Palghar recommends central IIP to talk to companies and gift few vials of EpiPen to every IIP member. IIP has 50 crore rupees lying in the box doing nothing. EpiPen will save us. If anybody orders 1 lakh vials, any company which makes pre-filled vaccines, they will make EpiPen. So मला तुम्ही जर कोणी रिकमेंड करा, सेकंड करा, आपण ते कळवून देऊ त्यांना.
Yes, Dr. Hemant.
पॅन ते हात वर करा आणि सांगा आम्ही सेकंड. हा, तर तू सेकंड करा आणि हे
Second.
अजून थर्ड पण कोणीतरी करा. यांनी पण केलं.
Second.
तू लिहून
Second.
घ्या अनुराधा. डॉक्टर हेमंत जोशी प्रपोज दॅट IIB Palghar recommends that center should talk to companies and to manufacture and buy first 1 lakh doses and gift to members. That will save
Yes.
our necks in emergencies. कारण ते EpiPen कोणी बनवत नाही, कारण खूप त्यांना मोठी ऑर्डर पाहिजे. 1 लाख व्हायला ऑर्डर दिली तर कोणी पण करेल, रेड्डीज करेल, भारत सिरम कोणी पण करेल. ठीक आहे ना? मी तुला
Yes,
लिहून देईल,
Hemant.
आपण ते पाठवून देऊ त्यांच्याकडे. डन. अर्चनाने पण सेकंड केलं, थर्ड केलं, 4 केलं, 5th केलं. करू, आपण लिहून घेऊ. पास म्हणून सांगा सगळे. पास
Pass. Pass.
Pass.
आपण
पास
करूया बरं का.
पास.
थिंग्स डू हॅपन. मी फोन करून बोलून घेईल, पण आपण हे पाठवून देऊ त्यांना.
ओके सर, थँक्यू.
थँक्यू.
Thank you, sir.
थँक्यू शैलेश. आणि
Anuradha,
मनोज छान
propose
केलं.
a vote of thanks
थँक्यू
to.
भरत फॉर जॉईनिंग.
Thank you,
Thank you.
Bharat. Yeah. Wonderful
हो.
Thank you,
CME
Dr.
today. Yeah.
Amit Jain, Dr. Manor Patil, Dr. Lalit Verma, sir, for your topics and interesting cases. Thank you all the delegates who are present over here. And thank you, Pallavi Dharmadikari, for technical support. And thank you all of you.
And thank you
Thank you,
MMC
madam.
observer Anuradha Palwankar.
Thank
Thank
you,
you, our
our
observer, Dr. Hemant
observer,
Joshi.
who keenly observed today's CME.
Thank you,
सरांचं लक्ष
everyone. Thank you.
सरांचं लक्ष असतं सगळीकडे. आणि त्याच्यातून नवीन काहीतरी